Okay, we're going to go ahead and get started. Hopefully everybody's doing okay and not tired or hurting or anything like that. And I'm switching to flip-flops, so I can't walk anymore in those shoes. Our first speaker this morning is Dr. Kelly Goldsmith. She's a professor of pediatrics at Emory University School of Medicine and an attending physician at Aflac Cancer and Blood Disorders Center. She is also the director of the Neuroblastoma MIBG program and clinical director of the Aflac Precision Medicine program. She received her bachelor's degree at Duke University, her doctorate at the University of Alabama, Birmingham, and did her residency and fellowship in postdoctoral research at Children's Hospital, Philadelphia. She is the author and co-author of, again, many publications, sits on many boards, including the COG and the NANT. She was also the co-chair of the study on the use of lorlatinib for patients with ALK mutation, and her discussion today will be on targeted therapy on ALK mutations and other possible targeted therapies. Dr. Kelly Goldsmith.
Thank you so much, Pat, and good morning to everybody. It's so nice to see you all. So I want to thank Pat and the organizers for inviting me to come give this talk to you guys, and I hope that by the end of this session, you'll have a little bit more understanding of some of the more common alterations and how to target them in neuroblastoma. So for this talk, I'm going to give you an overview of the most common tumor types that we treat initially with these targeted therapies, being recurrent and refractory high-risk neuroblastoma. We'll talk about therapies targeting genetic alterations in this tumor, which will include the results of our lorlatinib phase 1 trial that Pat mentioned. We'll talk about the role of circulating tumor DNA and tracking responses to targeted therapies. And then we'll talk about targeting tumor heterogeneity, which I'll tell you about in just a minute and define it, and overcoming targeted therapy resistance. So, as you all very well know, high-risk neuroblastoma patient outcomes, while they continue to improve, we still have a subset of patients who either don't respond to upfront standard therapy or their tumor comes back during therapy or afterwards, either right afterwards or even sometimes a long time after. And I wanted to kind of help you understand the difference between refractory and relapse disease, and these are really the patients that we're trying to find better therapies for. And as we find better therapies for our high-risk recurrent and relapsed patients, we actually pave the way to introducing new therapies to our newly diagnosed patients to try to prevent this from happening. So refractory high-risk neuroblastoma is really patients whose tumor does not respond completely to upfront high-risk induction chemotherapy. And relapsed high-risk neuroblastoma is when the tumors grow back in same or different locations, and they can occur anytime during or after upfront high-risk therapy is completed. So tumor sequencing of both diagnostic and relapsed neuroblastoma tumors has done an amazing job to help us identify new druggable targets in this disease. So prior research has shown that patients with newly diagnosed neuroblastoma really have mutationally quiet tumors. In other words, they don't have a lot of targetable genetic alterations at diagnosis. But what was elegantly studied and shown in these two Nature Genetics papers back in 2015, when they looked at diagnostic primary tumors and relapsed primary tumors, was that patients with recurrent high-risk neuroblastoma had increased number of mutations and different genomic mutations that might be targetable with unique therapies. And this led to the identification of ALK being enriched in relapsed and recurrent neuroblastoma. And we're lucky for that because the adult cancers also have ALK genetic aberrated tumors, and so there were ALK inhibitors already in the works for adult tumors. And other mutations in other pathways, such as the RAS and MAPK pathway tumor mutations, were also increased in patients with relapsed tumors. And there are new generation RAS inhibitors that are currently under investigation, but the inhibitors that are well known that are downstream of these mutations are MEK inhibitors, such as erlotinib and cobimetinib, as a couple of many examples. So let's talk about targeting ALK in neuroblastoma, because I'm sure a lot of you have heard of the ALK gene as you've been undergoing this with your children, both at diagnosis and recurrence. So ALK is called the anaplastic lymphoma kinase gene. It was first discovered in neuroblastoma by Yael Mose, where she discovered that patients who had a predisposition to develop neuroblastoma, so had a mutation in every cell of their body, that ALK mutations were the most common mutation in patients predisposed to develop neuroblastoma. That's only in 1 to 3% of patients. But then what she also found was that ALK was actually mutated in tumors that in patients not predisposed to developing neuroblastoma. So 14% of newly diagnosed patient high-risk tumors will have ALK mutations. That doesn't mean they were prone to developing neuroblastoma. It was just called kind of a somatic mutation, tumor-specific mutation. And as I mentioned, at recurrence, there's about a 30 to 40% of these tumors that have ALK mutations. And so this led Dr. Mose and others to really investigate what is the utility of ALK inhibitors in neuroblastoma. And so there was a phase 1 and 2 trials run of the first generation ALK inhibitors, such as crizotinib, in children with refractory and relapsed ALK-driven solid tumors. So there are other pediatric tumors that have ALK alterations. So anaplastic large cell lymphomas also have ALK alterations, and inflammatory myofibroblastic tumors did. And their response rates were pretty remarkable. About 90% to 86% of those patients with those recurrent tumors responded to these agents pretty remarkably. But the neuroblastoma patients really didn't have such a great response to first-generation ALK inhibitors. And what was understood later on is that it's because the ALCL patients and the IMT patients had what's called an ALK fusion. It's a different genomic alteration than neuroblastomas that have what's called a missense mutation or an ALK mutation. And the ALK mutations are inherently resistant to first-generation ALK inhibitors. There were second-generation ALK inhibitors that came along to overcome resistance to the first-generation ALK inhibitors, such as ceritinib, and a phase 1 trial of that agent was run in children with ALK-driven tumors as well. And the neuroblastoma patients still didn't have the best response rates. Only about 20% had a response to these second-generation inhibitors. And unfortunately, really responses, while they were good, were only limited to patients with a certain ALK mutation, only one of the 3 most common hotspot mutations in neuroblastoma, being the ALK R1275 mutation. And so, as I mentioned, it became clear that several neuroblastoma, what we call hotspot mutations, meaning the most common mutations we see that activates this protein in these tumors, are intrinsically resistant to first and second generation ALK inhibitors. As you can see on the, I'm trying to see if I can make this work. On the right is some animal studies showing that patient-derived tumor grown in a mouse, the black line is just the tumor treated with really nothing, and it just continues to grow over time. The line shows tumor growth over time in the blue line, which is with crizotinib at 100 milligrams. And then the red line is testing this new agent called lorlatinib, which is a third-generation ALK inhibitor, in mice harboring these very resistant ALK-mutated tumors, and they have a complete tumor regression that's sustained with the treatment. And I don't know if you can see it, but the dose is 10 milligrams compared to the crizotinib dose of 100 milligrams. So it's a very potent ALK inhibitor. So what is lorlatinib? So it's a third-generation ALK inhibitor. It targets neuroblastoma-specific mutations. So Pfizer actually developed this drug to overcome mutations that arise in lung cancer patients when they become resistant to first and second generation ALK inhibitors like crizotinib and ceritinib. Amazingly, those mutations actually happen to be the mutations that happen in neuroblastoma from the get-go. And so lorlatinib seemed like a really great option for our patients because it really targets the mutations that arise in our high-risk neuroblastoma kiddos. And so it targets these mutations. The other great aspect is it crosses the blood-brain barrier very well, and that's important in lung cancer patients who get metastases to the brain. We also know, though, and I know Dr. Kramer's going to talk about it, that we get CNS relapses in neuroblastoma. So again, we thought this is a really great opportunity to try this drug that might have an effect on ALK-mutated tumors that might cross over and be in the CNS. And patients with ALK amplification, which have a very poor prognosis, also are responsive to this agent. So this led Dr. Mose and I to run the NANT 1502 trial, which is a phase 1 study of lorlatinib in patients with refractory and relapsed ALK-driven neuroblastoma. So the goals of this trial were really to determine the toxicity profile in pediatric. It's a first-in-child study of lorlatinib, to really understand what's the best dose to use in our patient population, because it could be different and often is very different than the adult dosing, and to really see how does lorlatinib work with chemotherapy. Does it have more toxicity? Does it have a better effect? And so we looked at it both alone and with chemotherapy being topotecan and cyclophosphamide. And we also, interestingly enough, there are patients, adult patients, that have high-risk neuroblastoma that recurs. And so we specifically looked at pediatric population and the adult population with recurrent neuroblastoma. We also took this opportunity for the first time to really investigate what is the role of circulating tumor DNA in patients with a targetable mutation that we're using a targeted agent for. So one of the goals was to determine the overall frequency of that circulating tumor cell-free DNA and profile for tumor-specific mutations, to follow the ALK mutations over time, and to look and see if we could identify mutations of response or relapse or resistance to our ALK inhibitor specifically. So I'll tell you a little bit about the results of this trial, which we published earlier this year. We were very pleased to see that in terms of hematologic toxicity, meaning what happens to the blood cells with this drug. We know chemotherapy knocks blood cells down. We know that certain targeted therapies even suppress the bone marrow. Unlike first-generation ALK inhibitors like crizotinib, which does affect the blood counts, lorlatinib in the lung cancer patients in adults did not. So we were very excited to see if this was the same case, and indeed it was. So we found that there was no hematologic toxicity from lorlatinib when it was given alone. And in addition, it didn't increase the hematologic toxicity that we see with chemotherapy when lorlatinib was combined with chemo. So that was really exciting in terms of thinking about moving it forward to use for our patients, maybe with a standard of care approach later on. The common non-hematologic toxicities were exactly what they saw in adult patients, which was weight gain, pretty significant weight gain, increased cholesterol, and increased triglycerides. What we did find over the course of watching our patients and learning how to treat them while on lorlatinib, we found, just like the adult patients, weight gain and increased blood sugars that occurred in some patients that were a little bit more predisposed could be easily controlled with diet and exercise alone. And high cholesterol and triglycerides, we had a profile of different statin agents that we could use, and they could be well controlled on statins, which are HMG-CoA reductase inhibitors, or the typical cholesterol-lowering agents that a lot of adults get on for high cholesterol, and it's the #1 drug used for children with hypercholesterolemia. Rare toxicities were attributable to the high blood-brain barrier penetration of lorlatinib. This was very similar to what was seen in adults. Were what we call neuropsychiatric side effects. Importantly, this only really occurred in patients greater than or equal to 18 years of age, so not really our typical target population who have high-risk neuroblastoma or recurrent neuroblastoma. But it's important to understand how this affects, because we wanted to make sure that there were no untoward toxicities towards our patients if we move this into the upfront setting. And so some of those specific CNS toxicities were like memory impairment, mild cognitive changes. We actually had iPads that we did cognitive testing every single time they came in. And psychiatric symptoms, some patients had a little bit of delusions and hallucinations. Again, these were our adult patients, very similar to what was seen in lung cancer patients. And the worst CNS side effects that we saw were actually limited to patients who had a predisposing history of psychiatric illness. And so we actually amended the protocol to say, to really make sure we took good histories, and if you've been hospitalized or had any kind of depression, needing medication or anything like that. So these are really more adult psychiatric issues versus, let's say, a kid with ADHD. That's not a psychiatric issue. That's not what we're talking about here. So those were the only patients that really had a significant side effect, and then the therapy was stopped and not restarted. And that only happened in 2 out of the entire patients who were older than 20 years of age. So based on these toxicities and the response profile that I'll show you in just a minute, we did come up with the recommended phase 2 dose. For patients greater than 12 months of age and less than 18 years, the dose was 115 milligrams per meter squared. And I'm mentioning this because this is actually 200% of the adult dose, and we'll talk about that in just a minute. In patients greater than 18 years of age, we came to the decision that 150 milligrams was both tolerable and showed better responses. And so I wanted to take a second to tell you, why did we jack up that dose? Well, it's not uncommon in pediatrics that we use higher doses in children of the same drug that's used in adults, and that's often due to metabolism, how it distributes in the patient's body compared to an adult. But here, this really goes back to what we saw in the laboratory in Dr. Yael Mose's laboratory, and we also talked with our collaborators at Pfizer, who are our pharmacology MDs. And what we found was that our tumors that have these ALK mutations are very similar to lung cancer tumors that have not just the ALK fusion, but develop a resistance mutation on top of that ALK fusion that mimics the neuroblastoma. And those actually do require higher doses of lorlatinib in the adult lung cancer setting. And so neuroblastoma really more mimics those more resistant lung cancer patients. And that's why the dose is necessary to truly target the full-length ALK in our patients to have an anti-tumor effect. And so we're not just jacking up the dose till we think, it's too intolerable. There's actually a real scientific reason why we did that. All right, so let's talk about some responses. So the single agent response rate in patients greater than 12 months to 18 years of age was 30%, and this includes complete responses, meaning all the tumor goes away, partial responses, you have a really good response, but not everything goes away, and what we in NANT call the minor response, meaning we have sometimes a complete response in one area, like all the bone disease goes away by MIBG, but then you have stable disease in the tumor in terms of its size. So it's no longer metabolically active, but the tumor is kind of still sitting there, but doesn't show up by MIBG. And I'll explain why these minor responses are important in a minute. For patients greater than 18 years of age, the response rate was 67%, and in combination with chemotherapy, the response rates in patients less than 18 years of age was 63%. And if you look over to the right, that's just showing you, those lines tell you how long the patients remained on study, and I'll draw your attention to some of the yellow lines. So that's actually just what we would call our standard stable disease, meaning the patients either responded a little bit or didn't really respond but didn't get worse, but they remained on this therapy with a great quality of life for a very long period of time. So we do believe that lorlatinib is benefiting those patients as well. And I forgot to mention that we did allow patients who were pre-treated or had seen treatment with crizotinib and ceritinib, and they had responses. All ALK hotspot mutations had responses as well compared to the earlier generation agents. And interestingly enough, we had one patient with a germline mutation who happens to be that line at the very top in only dose level 1, and they had a remarkable response. And this is in keeping with the earlier ALK inhibitor generations, that patients who have a germline, meaning all the cells in their body have an ALK mutation, so they're predisposed to develop neuroblastoma, are exquisitely sensitive to these ALK inhibitors compared to other patients. And so I wanted to just show you, can I go back? Yes. So I just want to show you what is important about these minor responses. So if you look at the top lines, those are scans of showing you the best MIBG response. So it's from their baseline MIBG to how much it decreased over time. And so the left graph is showing you the patients getting lorlatinib single agent therapy that are less than 18 years, the middle is greater than 18 years, and the right is with chemotherapy. And if you look at the yellow lines, stable disease, the majority of the patients with stable disease actually had a complete MIBG response, meaning that their MIBG went completely away. It went negative, but their tumor didn't change by RECIST criteria. And so these patients were benefiting and were showing an anti-tumor response, but not in the way that we conventionally monitor tumor response by, did the tumor shrink by MRI? And so what we can say just anecdotally is Dr. Mose did biopsy a patient who had a complete MIBG response and had been on lorlatinib for a very long time and stable disease, and it actually, the tumor was differentiated. It was no longer a neuroblastoma. It looked like a ganglioneuroma, which is a benign tumor under the microscope. So we think this may be what's happening. I cannot tell you this is what's happening to every tumor of a patient with stable disease. And did some of these patients' tumors recur? Yes, they did. So I'm just giving you one example, but that's anecdotal. So here's an example of what I was talking about. This is a patient who had a, this is a hard pointer, who had a tumor over kind of in the little left carotid area that encased their vessels so they couldn't take it out. And it really didn't change in size from the beginning to course 4. But if you look at the MIBG, see how bright it is right there? Now salivary glands naturally light up, so those two on the sides are normal. But if you look at that, now look what happens. It completely went away by MIBG in course 4. This patient actually continued to have MIBG negative disease and had been treated for, I believe, 3 years, 2 years on study, and then came off study to continue commercial supply, and is currently with no evidence of disease. And so let's talk about circulating tumor DNA and how it might inform responses to targeted agents. So what is circulating tumor DNA? It's tumor-derived fragmented DNA in the blood that is not associated with cells. The exciting aspect of this is that samples from the blood can be taken out and the plasma can be separated out, which is the yellow liquid part of the blood apart from the blood cells, and that DNA hangs out in that plasma. You can take that circulating tumor DNA and look for tumor-specific mutations over the course of therapy. And as we all know, for solid tumors, we're not as lucky as leukemias. We can't just sample the blood to see if the leukemia is there, and biopsying isn't necessarily feasible in every situation for our patients. So could this be used to actually track our patients' responses over time and to look for evidence of new mutations that might confer resistance? So these efforts were led by Dr. Esther Burko, who was formerly at CHOP, and she looked at the circulating tumor DNA in our patients that was taken at baseline with every disease evaluation and at the progression of disease. And she identified that there were really 3 trends or categories that our patients fell into on this trial. About 50% of the patients, the ALK ctDNA mutations completely correlated with clinical response. It was high, it went down, and you could see on the scans that the tumor was going away. When the tumor looked like it was coming back, the ALK mutations were coming back. ALK and the ctDNA in other patients and clinical response actually did not match. So for example, that was in about a third of our patients, where she saw a decrease in ALK mutational burden over the course of therapy. However, the tumor came back. But if you look at the tumor ALK ctDNA, what you will notice is while the ALK mutations aren't there, there's new mutations that are arising. So more than likely, we're seeing an outgrowth of tumor on the scans that is no longer ALK mutated because the ALK inhibitor got rid of the ALK mutated tumor, but new tumors growing that didn't have ALK mutations and has different mutations. That's why the circulating tumor DNA, specifically looking at ALK mutations, were not present. And then in a third category, there are about 8 patients where the ALK mutations were not even detected at baseline in the circulating tumor DNA. We don't have an answer to this. My patient was one of those patients. She did have an ALK F1174 mutation at diagnosis in her tumor, but not in her plasma. And the majority of those patients all responded to therapy. And they did come back, and the ctDNA, when they progressed, did show ALK mutations. So another really exciting thing that we were able to identify were new mutations that told us what possibly could be causing their resistance to the lorlatinib therapy. And this, again, really, I want to highlight that on the left side, it kind of gives us an idea of why we may not want to give lower dose lorlatinib compared to the dose that we picked as our recommended phase 2 dose. So in some of the earlier dose levels, what Esther or Dr. Burko identified was when their tumor came back, not only did you see the ALK mutation that was in their circulating tumor DNA and their tumor at diagnosis, but now there were new ALK mutations. And this was really specific to those patients on the lower dose levels of lorlatinib. We can't explain why, but they're called compound ALK mutations. This actually was seen in lung cancer patients as well. So this is a common occurrence of resistance to lorlatinib. On the right side is really showing you the patients from baseline going over to when they have progressive disease. The different courses are on the bottom. And what this shows is that along with some ALK compound mutations that arise when the patient's tumor starts coming back, we see new mutations arise, and specifically in the RAS and MAPK pathway. And so this really goes along with what we were seeing as a response to standard of care therapy, that these RAS mutated neuroblastomas are pretty aggressive. And so despite seeing these mutations arising in resistance, these were pretty impressive responses for a phase 1 agent to a single drug given once a day by mouth. So it was really exciting and compared to the earlier ALK mutations. And so this led to a rapid translation of lorlatinib to replace crizotinib in the active and enrolling COG phase 3 trial, AMBL 1531. So an amendment was written and Pfizer agreed, and we worked together to transition patients who were on crizotinib to lorlatinib, and then the new patients who were found to have an ALK mutation at diagnosis were started on lorlatinib and along with standard of care chemotherapy. This trial is still ongoing, and I believe we've enrolled about 20 patients on this arm since we've started lorlatinib, and so we're very excited to be able to offer this to our newly diagnosed high-risk neuroblastoma patients, because we know, and I didn't mention it, but if your patient has an ALK mutation at diagnosis, they have a little poorer prognosis, and so we want to be able to offer them something to really improve their chances of cure. We also had an international collaboration, and these two transitions into these high-risk trials were supported by Solving Kids Cancer, and what they really encouraged and what we've done beautifully is collaborated to align our two high-risk studies from here and across the waters in the SIOPEN high-risk neuroblastoma 2 trial to include lorlatinib in that arm. They haven't opened it up yet. They're working with contracts, but that's the goal, is to have similar statistical designs, similar CNS evaluations, and to make sure that we are really accounting for what could be possible CNS adverse events or side effects of lorlatinib when given with standard of care chemotherapy for newly diagnosed high-risk patients. So I also wanted to mention that the Children's Oncology Group also has a match-type trial that is available for patients with solid tumors and lymphomas. It's called the COG-NCI match. And what they do is a tumor biopsy is done, and they do next-generation sequencing of patients' tumors, like that's how we discovered ALK in neuroblastoma. And when they do, they identify whether the patient has a specific mutation that would allow them to enter or enroll on a sub-study trial of a targeted agent. The current pediatric match sub-protocols are all single-agent therapy for patients with recurrent or relapsed disease. This is not for newly diagnosed patients. But in red, I wanted to circle some of the agents that are available on these match trials that target specific alterations in high-risk neuroblastoma. Most of these trials are complete, and in talking with Julia Glade-Bender, who is at Sloan, who is now in charge of the new match trials, they're going to be moving forward with combination therapies for patients with newly diagnosed, for relapsed high-risk tumors, which would include neuroblastoma. I don't know what those combinations are yet, though. So MYC-in, I'm sure you've heard, MYC-in amplification, even if you have a single tumor that's not resected, kind of pushes you up to a high-risk status in terms of risk classification. And it's amplified in about half of our patients with high-risk disease. So why don't we just target MYC-in with a MYC-in inhibitor? You can't. They don't exist. MYC-in is what's called a transcription factor, and transcription factors are very difficult to just target. ALK is different. It's a tyrosine kinase. It continues to signal, and we hit that signaling domain. So how can we think about new and exciting ways to target MYC-in amplified tumors? And I'm just going to go into a little bit of the science. Bear with me. I'll try to be real quick so I don't bore you. But I don't know if you remember back in science days, high school, college, or if you did a little biology further than that. You know, a gene is really DNA. It's made into RNA. The RNA is made into protein. And eventually, that protein can't stick around forever, and it's kind of tagged to be degraded over time. That's the life cycle of a gene to a protein. And so the MYC-in is amplified, so the gene itself has a lot of copies. And so there are efforts to really try to prevent this MYC-in gene from becoming RNA to make it into a protein. And so there are methods that people have tried to do to target the machinery that's responsible for making this gene into RNA. And so there are these proteins called BRD4 that bind with a lot of other proteins that actually are the transcription factor that turns on the transcription factor known as MYC-in. And so there are BET inhibitors or BRD4 inhibitors. There is a trial open at Boston of a BRD4 inhibitor for relapsed solid tumors, and it is enrolling. There's other proteins such as CDK7, which binds with this complex, and there are things called CDK7 inhibitors. There are some people at Boston who are looking to combine preclinically CDK7 inhibitors and BRD4 inhibitors, and there's been some publications of that, but it's not in a clinical trial yet. There's other agents that are responsible for other aspects of the gene being made into RNA being made into proteins such as the CDK9/2 inhibitors, but again, those are just in the lab right now. So once that RNA is made into a protein, how does that protein eventually go away? So there are proteins out there that help stabilize MYC while it's doing its job, preventing it from going on and being degraded like it normally would be. Those proteins are known as Aurora A and PLK1. And the job of those proteins is to stabilize MYC, keep it doing its job by preventing this gray protein called FBXW7 from binding to MYC and tagging it for degradation. And so what PLK1 and Aurora A do is they inhibit that agent called FBXW7, and MYC can keep doing its job, which is not good because it's an oncogene and it drives neuroblastoma. It's one of the most driving oncogenes there is. And there are Aurora A inhibitors. There are Aurora A and B inhibitors. I don't know if Araz is going to talk about that, but there were trials run through the NANT of a drug called alisertib and erbumine, and those have been completed. Some are already published, and one is not yet. There are also PLK1 inhibitors that people have been looking at from a preclinical standpoint, but I won't go into too many more details since Araz may talk about NANT stuff. So how can we target MYC indirectly? That's really the way that a lot of research is going because MYC is so hard to target directly. And so there are downstream targets of MYC, and I'm sure you have heard of them, and I know Dr. Brown may be talking about this a little bit more in detail from a different venue. But MYC is known to increase a protein called ODC1. And ODC1 helps make these building blocks of the tumor cells called polyamines. So there's a drug called DFMO, or eflornithine, that inhibits ODC1, and by doing so, it can kill neuroblastoma cells. In the NANT, we have shown that high-dose DFMO in combination with chemotherapy is safe and tolerable, and that data will soon be published by Dr. Hogarty and the NANT committee. But what Dr. Hogarty's lab also has shown in conjunction with his collaborator, Dr. Basiri, is that ODC1 and MYC, downstream of those polyamines is this other protein called arginine. And arginine is known to be very immune suppressive. It suppresses immune cells. And so DFMO, by inhibiting ODC1, it inhibits arginine, and those immune cells wake up. And so what he's shown is by using DFMO that you actually see increased immune cells, increased good cytokines. And so it made us think, well, is there a role for DFMO in combination with immunotherapy in neuroblastoma? I know you guys got an earful on immunotherapies yesterday. And so we all know that everybody's working really hard from the research, clinical and preclinical side to really improve how this chemoimmunotherapy works. And so this led Meg Macy and myself to propose ANBL 1821, which is a randomized phase 2 trial of dinutuximab, irinotecan, and temozolomide with and without DFMO in patients with relapsed and refractory neuroblastoma. It's actually currently open and enrolling at the majority of COG institutions. And we're really trying to understand, does DFMO improve dinutuximab and chemotherapy response by inhibiting polyamines and activating patients' immune cells, which are needed to respond to dinutuximab. So DFMO is given daily for 28 days, but because it's high dose, we give a 1-week break to avoid ototoxicity because they can have hearing loss from high-dose DFMO. And irinotecan and temozolomide and dinutuximab are given like they're normally given over the course of that 5-day period. And we are testing patient samples in my lab for immune cell changes in response to DFMO, a 1-week lead-in, as well as during the course of therapy to understand biomarkers, immune biomarkers of response. And Dr. Reynolds, who'll be talking to you later, is evaluating patient bone marrows and blood for GD2 tumor expression as well. So I wanted to take a step back. There's a lot of really exciting targeted therapies, including lorlatinib, that are there. We're all trying to investigate and identify new ones as well. And there are challenges. So relapsed and refractory neuroblastomas are really chemotherapy resistant. And neuroblastomas are what we call heterogeneous. Not all tumor cells within the same tumor in the metastases actually have that gene mutation like ALK, or express that cell surface protein like GD2. So can we identify new tumor-targeted therapies that might have a better way of killing off all of those cells? Should we combine our targeted therapies with chemotherapy so that we can have the targeted therapy kill the ALK-mutated cells while the chemotherapy is acting on those cells that may not be ALK-mutated, or in combination? And as we've heard, and we'll continue to hear, that can we give immunotherapy to overcome those tumor cells that are not mutated? So I'm just going to take a brief moment just to talk about some new things that are going on at our institution to maybe address neuroblastoma heterogeneity. So as you all know, new immunotherapies can kill tumors regardless of tumor-specific genetic mutations. And so CD8 T cells require chimeric antigen receptors to be able to activate and kill the tumor cell. So most use patient-derived CD8 cells because if you don't, these CD8 T cells could cause GVHD if you got them from a healthy individual. And along with that, there has been research to show that neuroblastoma patient T cells are very tired, even at diagnosis and then after chemotherapy. And these are the cells you're using to give back to the patient after you expand them, engineer them, and put them back in the patient. So they may not be as robust as healthy donor cells. Not all tumor cells express the CAR target of interest, so you are limited of that CAR T cell targeting only those tumor cells that express that antigen. And the tumor microenvironment suppresses those immune responses. So we've been looking at another immune cell subset called gamma delta T cells, which are a lot like NK cells. They're already armed and able to kill the tumor cell without any genetic engineering. They are actually able to improve antibody killing because they have high expression of this antigen called CD16, which is on the surface of the cells and necessary to recognize dinutuximab-coated tumor cells. They are not reliant on MHC, so they actually do not cause graft versus host disease and offer the ability to give an off-the-shelf allogeneic product. And I know that that is also a possibility with NK cells that I think either they talk to you about or are going to talk to you about. Araz may mention that as a future study in NANT, the NK cells. And that's really a focus. The other thing that's really great about these gamma delta T cells is they can recruit and activate other immune cells. So even if you engineer these guys to recognize a tumor antigen, they can recruit other cells to kill all the tumor cells. Interestingly, there's been studies shown that when you have tumor-infiltrating immune cells, just when you take out a tumor and look at what's making up that tumor besides the tumor cells, they're actually immune cells that sit there. Most of the immune cells are suppressed. But what they showed was that if you have gamma delta T cells in your solid tumor in a huge category of different tumor types, that the number one immune cell that was associated with an improved prognosis with the gamma delta T cells in those tumors. And so can you run that video real quick? I'm a visual learner, and so this is kind of fun. So we treated some neuroblastoma cells with dinutuximab, and then we came back in with these blue gamma delta T cells. So the green cells are the neuroblastoma cells. And as you can see, these are unengineered, unmodified, just expanded gamma delta T cells. And you can see the green cell blebbing. It's about to pop. And the other one on the far left just completely got killed. And so that's what gamma delta T cells do to neuroblastoma cells. And those are human-derived gamma delta T cells from an allo product, and that's a human-derived neuroblastoma cell. So kind of fun. I like showing that. So we took these gamma delta T cells, combined them with dinutuximab and temozolomide in a mouse, and showed complete tumor regression, which is that red arrow, in very aggressive mouse models of neuroblastoma. We also think that adding zoledronate in combination with this chemoimmunotherapy and cell therapy might improve gamma delta T cell therapy in the patient, because zoledronate is actually what we use to selectively enrich for gamma delta T cells outside the body. It's a bisphosphonate that's safely used in neuroblastoma patients, and it sticks around for a while and can also help the gamma delta T cells home to bone sites of the tumor. And so we looked, should we use autologous gamma delta T cells? And long story short, because I don't want to go over, I want to give you guys time to ask questions. Gamma delta T cells make up a very tiny percent of the immune cell population in a person. And patients actually undergo apheresis already for standard of care, and we always have what I call rainy day bags of stem cells. We've been able to expand gamma delta T cells from patient-derived apheresis products, but because these gamma delta T cells are from a healthy donor, we think they'll be better given that neuroblastoma apheresis products are in high demand. We're now giving MIBG up front. We're giving 2 tandem autologous stem cell transplants. We're not going to have a lot of apheresis products, and putting a patient under apheresis again is a lot to ask of a patient, especially at the setting of recurrent and relapsed disease. So we think that a healthy donor product will allow us to give more infusions and a stronger product. And so this led us to propose a phase 1 study of ex vivo, meaning outside the body, expanded allogeneic, which means healthy donor, gamma delta T cells in combination with dinutuximab, temozolomide, irinotecan, and zoledronate in children with refractory relapsed high-risk neuroblastoma. And so our goal, it's an AFLAC investigator-initiated study that I'm the chair of. It's open to enrollment. It's currently a single institution. We hope to expand it past this, is really to determine what our recommended phase 2 dose of the cell therapy product will be in combination with this chemoimmunotherapy and zoledronate combination, what the toxicities are, as well as what the responses are. We're also going to be doing some immune profiling to see how these gamma delta T cells, if they do indeed wake up the patient's innate immune cells while it's also fighting the tumor itself. So we're really excited about this trial and are excited about enrolling some patients on it. So in conclusion, I hope I've shown you that drugs targeting neuroblastoma specific mutations can be very effective if they're targeting a genetic driver mutation like ALK. Lorlatinib shows a strong promise against ALK-positive neuroblastoma and is now being looked at in the newly diagnosed setting. Serial circulating tumor DNA can be used to track responses and identify emerging resistance mutations to targeted therapies like lorlatinib. And we can use ctDNA results for clinical decisions, but really what the utility of that is still under investigation in terms of in the setting of not having a targeted therapy or a targeted mutation specifically to follow. Drugs indirectly targeting MYC and gene expression, protein stability, and downstream targets are still being investigated, but we're learning sometimes it doesn't carry over into the patient to have the same effect as we see in terms of targeting MYC and amplified tumors specifically. And other targeted agents I didn't talk about that I believe Uraz will probably talk about, such as MIBG therapy, which truly does target neuroblastoma as well, will probably be discussed in upcoming talks. New cell therapies derived from healthy donors, such as allogeneic gamma delta T cells and NK cells, have innate tumor-killing properties without being engineered and may help overcome this solid tumor heterogeneity because they don't just target the tumor antigen-expressing cell, they target all of the cells. Every child with relapsed and refractory high-risk neuroblastoma is unique. I can't stress that enough. What works for one patient may not work for another patient. The first choice and the next choice, and the next choice for relapse therapy, because we know we often go one to the next, is really based on how the patient's doing, their genetic alterations identified, which it's very important to look at relapse, what those genetic alterations are, not from the diagnostic tumor when you're trying to treat your relapsed child. And trial availability and prior responses and toxicities on upfront or other relapse therapies are very important to consider when thinking about that next best treatment to our goal, which is ultimately to cure all of our patients. So I'd like to thank you guys, and I'm open for questions, and especially to thank our patients and parents who we would not learn anything without you guys enrolling on our trials, benefiting from the therapies, and we benefit from you as well so that we can continue to move this forward to improve our responses. So thank you.
Thank you. Does anyone have any questions? No? Nothing to, oh, okay, we've got a few of them starting
Okay.
here. Here we go. We'll do one here and then one over there, and then we'll do you.
If you're allowed to share, Margaret from Tennessee, my daughter was treated at Vanderbilt. The clinical trial that you did with Dr. Macy, are you allowed to share what results you've noticed so far? No. When do you think that will be published?
It's an ongoing trial. We
actually
don't get the responses.
We were in it, but we didn't get the arm with DFMO, so I'm just very curious.
Sure.
How long, is there even a guesstimate of when those results would be published or out?
That's a great question. So we've had some opening and closings based on just some drug and shipment availability of the DFMO, and so it was delayed initially, but now we're back on track. And once we're on track, we usually enroll pretty well. So we anticipate that we'll be done with enrollment by probably early 2024. And based on that, then the responses usually come, the results come later. It just really depends on how quickly we have central review of responses, and that takes some time as well. So sometime in 2024. Yeah, and unfortunately, they don't share it with us either. It's everything's blinded to us as well.
Okay, we had one more back there.
Yes.
Hey, okay. I know the DFMO, the high dose with, chemoimmunotherapy, it's not available for relapse patients who have already had chemoimmunotherapy. Is that right?
No, they
So
can have it. They just couldn't have progressed on chemoimmunotherapy, I believe. Or wait, no, they can't. Yeah, it's first relapse. So yeah, you're right.
Right.
They can't.
And
Usually when we have that, they can't have progressed through it. They can't have progressed on dinutuximab during induction therapy. Sorry. Thanks, Ross.
yeah, so is that the same for the gamma cells? Like if you've already had chemoimmunotherapy, could you enroll on the trial for the new gamma T cell?
The gamma delta T cells?
Yeah.
I believe you can't have progressed through it. I'll make sure. But yes, you can have seen it before. You just can't have progressed on it.
Okay.
So if you had it, switch to another therapy for one reason or another but if your disease progressed on or shortly after that, then you're not eligible for
Right.
it. But if you've had it before, yes.
You could still get the gamma T cell.
Correct.
Okay, thank you.
Yeah.
Okay, we have a question.
Two quick questions.
Yes,
One,
ma'am.
how common is it for a patient who wasn't diagnosed with the ALK mutation at diagnosis to then at relapse have the ALK mutation? And then two, you spoke about ODC1 and its relationship with polyamines. So Ella was on the ANBL 1821, did very well. But the question is always, what role, if any, does diet and low polyamines diet play when taking something like a DFMO?
No, they're very good questions. So to answer your first question, if you think about it, newly diagnosed patients, about 14% have ALK alterations, and then about 30 to 40% at relapse. So there's definitely more that are going to have it at relapse. So if you didn't have it at diagnosis, I would definitely check at relapse. I think we're going to get more sophisticated with time. I didn't mention, but we did not make eligibility based on circulating tumor DNA, right? We made it based on the tumor-specific mutation, and it could have come from patients from a diagnostic tumor to a relapse tumor, because we definitely know that patients who have it in the beginning usually have it at relapse. It's just there are some that do emerge over time because we're probably killing the less resistant cells with our upfront therapy and allowing those ALK mutated cells to now take over. So there was data to show that there were what we call subclonal ALK mutations that probably weren't picked up by the earlier sequencing that we used that we're now seeing. So there's a possibility that there were a couple of cells there to begin with. We're going to get more sophisticated in terms of being able to dive deeper into our tumors with our next generation sequencing to identify those. The role of lorlatinib in patients with subclonal ALK, we don't know yet. And so we still need to understand that and investigate that a little bit more. But I do believe we will follow the Pfizer bandwagon later on, in that at relapse, if you do see ALK alterations in the circulating tumor DNA, do you really need a biopsy to be able to put a patient on lorlatinib? And they are allowing circulating tumor DNA now. And I remember when they were starting to compare, what does the tumor look like? What does the circulating tumor DNA look like? And then they were able to move over. I have a feeling we'll go there. And there's been, including Dr. Mose and others, they've created these very deep sequencing circulating tumor DNA panels to really identify that. It's just, what's your cutoff? What's your ALK mutation frequency that we will allow for that? So that hopefully answers your first question. Your second question, we don't feel strongly that a diet, low in, arginine and things like that and polyamines really will affect your tumor. It's kind of the same thing as what we see with adults trying to modify their diet to treat their tumor or to prevent it from growing more. So we don't require that. I think the best thing to say is you need high-dose DFMO to really inhibit all polyamines. And so to think you can do that with your diet is probably not possible. And so that's why we know low-dose DFMO really doesn't have a role, and high-dose really seems to have an effect, but we have to make sure that we're careful to monitor for the toxicities that you can see, because DFMO does affect your ear. It's reversible, but the higher the dose, the more it affects the cochlear area. So
Okay,
it's a
one
good
more
question.
question?
And all the kids that you're treating for, or monitoring for ALK, for your ALK treatments, are all of them being closely monitored with liquid biopsy?
That's a great question. So for us, yes, they are. I mean, for my institution, we do. I know a lot of people are jumping on that bandwagon to do it. If they have an ALK alteration, most people will get that because it's a very nice, non-invasive way to look. We constantly will revisit, okay, do we act on this, right? So if you see an ALK mutation coming up or a RAS mutation coming up, but the patient's doing well, I don't think any of us would just stop the lorlatinib, and we would wait to see if they have a radiologic progression. And there's a couple of reasons for that. I don't think we understand completely the circulating tumor DNA and at what point does it truly predict a progression or a relapse. As I mentioned, there were those three categories, right? Even on lorlatinib, sometimes the circulating tumor DNA did not predict the disease progression for different reasons from an ALK mutation standpoint. But the other reason is if you stop lorlatinib, even if you are starting to progress on it, the adult world in lung cancer has shown us that you actually can get a more rapid progression. So sometimes we will monitor it on lorlatinib and not bridge too long off of an ALK inhibitor before you go to that next therapy to prevent the tumor from progressing even more quickly, because you kind of have a stop on it. And you remove that eraser and it just is going to start taking off, even if it's starting to slowly progress on that drug. So we don't really want to just stop it without a plan. And so actually a lot of us when we were having patients on crizotinib and ceritinib who were transitioning over to lorlatinib on the phase 1 trial, the pre-treated patients, our window of what we call the washout window of how long you have to be off of a therapy was very short. Whereas it's usually like 2 weeks to 21 days, it was like 6 days. And so we made it very quick because of the experience Pfizer and the lung cancer oncologists had with patients being on these targeted ALK inhibitors. So, but we do like to follow them. And there's lots of different ways that you can do it. There's commercial ways, and there's other clinical testing.
Thank you.
Yeah, absolutely.
All right.
Yes,
And
ma'am.
last question?
Hi, sorry. So I'm intrigued, and I'm like, with the 1531 that has like all the different arms, and being able to see that ALK arm, not only because it's going to be more beneficial for, kids with that ALK mutation expression to be able to receive that lorlatinib up front, but it also means that sequencing is taking place at diagnosis. So, I mean, we did Frontline in 2014. That was not an option. That was not something we ever did. We didn't get any testing done until, tumor resection for, 4 cycles in. And by that time, we didn't have a lot of information because it was pre-treated. And even when we relapsed 7 years later, 7 years after initial diagnosis, I had to advocate a lot. I asked a lot of questions of how do we get some genetic testing done? How do we do this? How do we, And I feel like my son was failed. It took 13 months of advocating to finally get a test done, which ended up being the ctDNA test because of the power of parents and networking. So I guess my hope is that with this study, it's going to help doctors do that for their patients up front, because we all know as parents, we've been in that deer in the headlight. We're at the mercy of our doctors when our kids are first diagnosed. We have to put our full trust in our doctors to lead us in the right direction. And we don't know those questions to ask. We don't know to ask, is there any genetics testing that can be done on my kid's tumor? We don't know that at diagnosis. So I guess my question is, how do we ensure that this is going to be happening, for kids,
Upfront.
for all upfront at all institutions, versus a doctor that's just going to be like, we're just going to pop you on here
Yeah.
on this, standard protocol, something like that, where it's
So-
in a patient's best interest.
That is a brilliant question, and it's at the perfect time. So I'm actually on the biology committee of the Children's Oncology Group, the Neuroblastoma Biology Committee. And I don't know if any of you have heard of this, but the Children's Oncology Group and CTEP, the NCI, has a new initiative called the Molecular Characterization Initiative. And it's really a goal to do exactly that. I think what we don't want happening is smaller institutions that don't do their own in-house sequencing, and then you've got the big institutions that's doing it on everybody because it's funded by the state, like New York, right? And so you don't want this imbalance. And so what the Children's Oncology Group and CTEP, the cooperation they have is like, let's reduce that imbalance. And so what they're offering is next generation sequencing for specific tumor types, and it's rolling out slowly. But I'm happy to say that it's going to be rolling out for neuroblastoma at diagnosis for the high-risk patients. And so if there's a patient that has any possibility of being high risk, then they will, if they enroll on the neuroblastoma biology study, they will get the molecular characterization initiative, which is next generation whole exome sequencing, methylation profiling, and that stuff. That will help us understand the MICN. That will also give us ALK. And so while 1531 will be closing soon, the arm that has the ALK will remain open. And so that will still be available for certain patients who get this molecular characterization initiative, so that even when 1531 closes, they want to accrue enough patients to show that it makes a difference in these patients' survival. And those ALK mutated patients discovered by the what we call MCI will have the opportunity to enroll on that study. So I think we're right at the cusp of doing exactly what you desire. Don't put it in the hands of the family, put it in the hands of the institution. All of us, the majority of us, are Children's Oncology Group sites. And I think those big ones that have their in-house sequencing anyway, or if they don't put patients on the biology study, they have in-house sequencing. But most of the smaller institutions are, as well as Children's Healthcare of Atlanta is, CHOP, CHLA, and Sloan Kettering, everywhere. We're all part of COG. And so I think that this will give us an opportunity. What we want to do is encourage families when they will tell you, we have this biology study that if you want to be on a clinical trial, you have to enroll in the biology study. Part of this biology study is next generation sequencing of your tumor if it's metastatic, large, but we don't know if it's metastatic or MICN amplified and that kind of stuff. For the low risk neuroblastoma tumors that are localized and what we call an L1 tumor, they really don't need that next generation sequencing from that standpoint because there's not going to be anything to target, and oftentimes they don't even need therapy at all. And so this was something that we worked with COG to do. We would love to do every neuroblastoma that comes through the door, but there's only so much money through the government, right? And so we're starting to make sure that we can do it on the patients where it matters, the ones that might benefit from an ALK inhibitor, that will give us some information to help us learn how to treat them better. So we're close. And I do believe, and there are other institutions, we do not hold that back from institutions that do their in-house sequencing. It's not going to be like, oh, well, you've got your own, we're not going to give it to you. So it's going to be the same across the board, and it's a very good sequencing platform, so it should catch that.
Thank you so much.
Absolutely. It's
All right.
great. And earlier in the 2014, we just not everybody had it, and we didn't know what to do with it, and we didn't have lorlatinib. And so I think we're getting smarter as we go along, and COG's noticed that. But thank you.
Okay. Thank you, Dr. Goldsmith. Our next speaker is Dr. Shahab Asgharzadeh. Did I say it correctly? Is the director of the Neuroblastoma Basic and Translational Program at Children's Hospital Los Angeles. He's an attending physician in the Hematology, Oncology, and Blood and Marrow Transplantation Department and an associate professor of pediatrics at Keck School of Medicine at USC. He went to medical school here at the University of Illinois in pediatrics and did his residency and fellowship at the University of Chicago. His lab at CHLA is working to identify the genetic differences in children who get tumors, neuroblastoma included, versus children who do not. His research is geared towards understanding the different outcomes of neuroblastoma, where the tumors have spread all over the body. His talk today will be on neuroblastoma biology and understanding molecular versus cellular therapies for neuroblastoma.
Thank you, Pat, and it's a pleasure to be here. It's my first attendance at this conference. And Pat emailed me and asked me to because I think a parent's request to discuss a paper. And I was like, oh, sure, I could talk about that paper. Then I read the paper. I actually had read it earlier, but it's a lot of differential equations and Bayesian statistics, but it's got a lot of biology. It's interesting and controversial. So I figured I'll start talking about that and go really basic at the first to describe some basic biology and genetics. So you have to bear with me, and for those who are biology aficionados, excuse that, the basic aspect of it. Before the disclosure, I'm a co-founder of a company called Simirex. It's interested in CAR T cells, especially for neuroblastoma, and I will not discuss the off-label use of therapeutics. But going back to the basics of biology. So this is going really basic, so I wanted to get you guys to the paper, because the paper is very complicated, but interesting. So as Dr. Goldsmith briefly mentioned, there's this concept of, cells, and I'm talking about reverse back here, from gene, DNA, RNA to protein to cells to organs. And why I'm talking about this will become hopefully clear soon. All of us have different organs in our body that are made up of cells. These cells are very organized, and when you look at them under a microscope, they're very structured. And basically, when we diagnose a tumor, it's a similar idea, taking the tumor tissue, cutting it up, putting it on a glass slide, throw some color at it, and looking under a microscope and seeing whether there's disorganization or organization. This is an example of a liver tissue. Now, the liver tissue, each cell has made up of anatomy of it, which includes a nucleus and other organelles that have a certain function. So all our organs do a certain function, and the requirements for those functions are basically made up of these machineries called proteins. So what are proteins? Proteins are basically, in my opinion, you can think of them as Lego pieces. They're Legos that are functional, and they do a certain function. Each Lego is made up of these building blocks. There's 20 of them, 20 amino acids, or you can think of 20 different Lego pieces that make a whole different types of Lego structures that do a function. And every organ does a different thing slightly. So your liver is basically supposed to detoxify alcohol, clear up of our metabolites in our body, and it produces machineries, or these Lego pieces, that do that function. Versus a heart cell doesn't need those machineries. It makes different types of machines. But they're all abide by certain rules. They're all confined to their own structures, and they don't invade other tissues. This is really much different, and we're talking about different functionality of these organs. I want to point out the fact that there's about 20 to 25,000 of these Lego structures that could be made in any cell. But each cell at a given time uses about 8,000 of these proteins to do its function. And there are subset classes of proteins, or these Lego structures, that are present in every cell. So they're used for dividing, for example, making an exact replica of the cell. So in your bone marrow, your blood cells frequently divide because they need to be produced new, versus your brain cells don't need that much division. So there's a lot of proteins that are involved in rebuilding that entire cell, the entire structure, over and over again. So these Lego sets are used for replicating. There's also, again, specific ones that do the specific function. Adrenal gland, which is the site of a lot of neuroblastomas arise from, are really for regulating your blood pressure, regulating some of your hormones as well. And moving on, again, bear with me for one more lesson in genetics, close to it, is going into how these proteins are made, right? It's actually a really beautiful way they're made. All the instruction sets for all those 25,000 structures of Legos that you make are made in a book, right? This book is basically built in a language that has only 4 characters. It's an English language. The 4 characters we call ACGT. And the book is about 3 billion characters long, and it's divided into chapters. The chapters we call chromosomes, and there are passages within these chapters that we call genes. And those genes, what we call genes, they're actually the building structure, the instruction set from how to make that Lego structure, the building block. And every 3 characters gives you specificity to one Lego piece. So when you read this thing, it says ATG, ATT, you've seen this thing in a lot of different things. Every 3 characters basically determines which Lego piece you put in front of the other one, and you build these things out, and your protein structure could be 100 pieces of Legos, or it could be 1,000 pieces of Legos. Whatever the function it produces, it's built that way. So the difference between each other is that every cell that we have has 2 copies of these books, 3 billion characters in length. One is from your mom and one is from your dad. And the differences in us is basically there's alternative spellings that occur in these passages that make the protein slightly do different functions, slightly, but that gives us our uniqueness because each cell has a copy of it. And they only have 2 copies of the book. And each book has 23 chapters in it. It's duplicated, 46 chromosomes total. And when there is a mutation, what we call a mutation, as you guys think about the ALK mutation, the mutation is nothing but a bad spelling. It's basically an error in the spelling of that instruction set for making that protein. So the mutation would basically lead to a protein that has a different function or loses its function completely. So when we talk about ALK mutation, when we talk about MICA amplification, it's basically that passage, which is in chapter 2, verse part 1, is basically under a Xerox copy machine and replicated multiple times, sometimes 20 times, sometimes 50 times in a cell. But again, remember that each cell has only 2 copies of the book. Now, what happens with cancer? Cancer is, you could think of it as a dysregulated organ. So you basically have now an organ in the body. The body recognizes it as an organ, doesn't think of it as a foreign initially, and we'll talk about that why. But it doesn't abide by the rules of this book anymore. It deletes parts of the passages, it deletes chapters, it Xerox copies other passages, or Xerox copies the entire chapters, and it no longer has what equivalent of the 2 book. It has different chapters missing or chapters completely replicated, as this sort of image shows. And it makes certain proteins more or less, and it invades other organs. And it also produces certain proteins that dampen your response to that organ that's dysregulated. So that's why it's actually formed, because body doesn't recognize it, recognizes itself again. So the T cells that are supposed to basically go and actually kill this tumor are no longer doing their job. Okay? So in neuroblastoma, basically the normal adrenal gland should have 2 books, the equivalent of 6 billion characters. It should have 2 chapter 1s, 1 in each book. Chapter 2 all the way to chapter 23. In a lower risk neuroblastoma, what typically happens is the amount of characters that are present is about more than 2 books. It could be 3 books, could be 4 books, sometimes 5 books worth of characters. And there are whole chapters that are completely duplicated or chapters that are completely lost. So we call these chromosomal duplications or chromosomal deletions. Just think about it again as chapters. Versus in the higher risk neuroblastoma, there's about the same number of pages or characters in 2 books, but what's happened here is there's regions of the chromosomes that are deleted or amplified, duplicated. Parts of the chromosomes, parts of the chapters are missing, part of them are gained. And this basically concept is sort of like what we look at when we actually get a tumor out, and we could analyze this and give you an idea of whether you have what we call segmental chromosomal aberrations, which is a fancy word for saying you have segments of your chromosomes missing or deleted or duplicated. Another concept I want to go back to in a second, or right now actually, is for each chapter, the book is a little bit unique because at the beginning and the end of the chapter, there's bindings that are very strong, and these bindings maintain the integrity of that chapter. And those bindings are basically in biology called telomeres. So the tumor cells really try to maintain those bindings so those chapters are intact, because otherwise it will die. So what does this actually look like in real life? You have a low-risk tumor on the left-hand side. The 3N means that there's about triplicates of the copies of the book. Those are chromosomes, or those are the chapters that I'm mentioning. And we actually could look at them, and we could count them, and see there's 3 of them or 4 of them, so that we know which chapters are gained or which chapters are actually completely deleted. In the middle, the other 2 sections are about 2 ends. Those are basically showing that there's chapters that part of them are deleted and part of them are gained. Sometimes a chapter goes and binds to another chapter at the end of it. So there's one section let me see if I could, oh yeah. So that one, the chromosome 17q is basically added. And then on the right-hand side, you see the same chapters, but you see these tiny dots there. Those tiny dots are actually MECN DNA that are so much replicated on the Xerox machine that in the cell you could actually see them. They're actually present, and they're giving the instruction set for the cell to make the MECN protein. All right. So another interesting thing about neuroblastoma is that there are repeating themes of chapters being deleted or gained across neuroblastoma. So 17q, for example, is often seen amplified or duplicated in 2 copy numbers in neuroblastoma cells. So, 2 more slides about basics of genomics. So going back to the mutations, there's one other concept I want to talk about, which I talked about a little bit, is this variance of alternative spellings. So the variants are basically spelling changes that cause minor or no change in the function of the protein that occur in the book as well. And you guys also will hear about epigenetics and epigenetic drugs. All that is basically is that the spellings aren't changed, but there's 2 highlighters. One that's like a yellow highlight that the cells basically go across a passage and means that like really explain that or produce that protein more without actually duplicating it. Or you could have like a black marker, which also you could go across and highlight, and that says do not produce that protein. So it's an alternative way of regulating the amount of the instruction sets for that particular machinery or protein that you want to make. So in neuroblastoma, there is mutations that have a really large effect size, so ALK and FOX2B, that like gives rise to the tumor driving it. And there are these mutations that have a lower effect size, means that you have to have multiple copy of them. Even the alternative spellings that actually have to have multiple copy of them to give rise to a particular tumor. And this is sort of shown that the names of them. And again, a mutation is something that when you change the instruction set, it leads to either a loss of function, so you lose the wings of the plane, they can't fly anymore, or you can have alternative spellings where you give maybe different markings or maybe a stronger engine, and that's what basically occurs. So, key things is that neuroblastoma is a complex dysregulated organ. Each cell now, remember, has its own books and passages with, again, repeating themes of certain chromosomes being deleted. Not each cell in a tumor has the same chromosomal or chapter changes or passage changes. So not every cell has an ALK mutation, but a majority of them do. Tumor cells can, when they replicate themselves, they can introduce new alterations, new spellings as well into the tumor. And the tumor growth basically is equivalent of evading your own immune system. And there's few tumor cells within here that act as progenitors. So there's a concept that's coming into neuroblastoma as there's phenotypes in neuroblastoma where we call mesenchymal versus adrenergic. A majority of the tumor cells are adrenergic, but these mesenchymal cells, we can think of them as sort of like progenitors, that when you give the chemotherapy, you kill a lot of these adrenergic types, but we think these mesenchymal types of neuroblastoma stick around the body and give rise to more adrenergic or their progenies as well. And when we look at a tumor under a microscope, it's complex. It's got endothelial cells which deliver oxygen through red blood cells. There has other immune cells that are now co-opted to help the tumor grow. It has support cells to help the structure of the tumor. But all of this, sorry for the first 10 minutes, was to get you guys to a couple of other places. So last point, just to tie up this basic biology, is when you think of chemotherapy, chemotherapy is nonspecific, and it basically goes after the proteins that are involved in replicating the cell. So anything that divides fast, basically, you guys already know this stuff, is what chemotherapy attacks those particular proteins. Versus a targeted therapy that Dr. Goldsmith talked about is basically aberrant proteins, the proteins that are produced abnormally high, or that has changed, that we could actually target now those proteins because they're only specifically highly produced in tumor cells or aberrantly produced with this alternative function or alternative Lego structure that we could attack that modified structure. So this was the paper that Pat said, Shahab, can you talk about this? So it said, neuroblastoma arises in early fetal development. Its evolutionary duration predicts outcome. And this is a couple of the figures that the paper they're talking about. And I thought about giving a differential equation talk as well, but I decided against that. So but the genetics was important to get you guys to the next topic. So, incidence of neuroblastoma. It turns out that at birth, the first year of life, the incidence is about 70 children per million children. And you may think that's really high, which it is, but we don't actually diagnose a lot of these children because we used to. In the 80s and 90s, we actually did a screening test where we took the urine from infants at 6 months and 9 months and tried to see whether they have telltales of neuroblastoma in their body. And there were a lot of children that we identified. That's why the incidence is so high. But it turns out most of those children had these neuroblastoma that are very low risk and they go away on their own, basically. We never see it. Japan tried to take them out, and they did. But what happened is we found out that all of that work basically did not decrease the number of children that would have a higher risk tumor later on at 2 years, 3 years, 4 years of age. So that practice was stopped. But the incidence is high in the first year of life. And typically, the kids that are less than 1.5, 2 years old, except for those that have a MICAN amplification, have a low-risk type of tumor, and the ones that are older have a higher risk of tumor. So I mentioned the screening infants did not identify children that were high risk. And what also is really interesting, when we look at the protein content, again, so what type of proteins are produced in neuroblastoma cells, it's really similar to the proteins that are produced in early neuroblast cells that are seen in the first 8 weeks of gestation. The question becomes, is neuroblastoma cancer of adrenal gland cells in older children that de-evolves, means goes back in time, and produces these proteins that are like, resembles the early neuroblast, or is it really an embryonic cell that's formed really early in pregnancy and just sits there for a long time quiescent before it actually develops into a neuroblastoma? Or do we have these cells all in our body in infancy that are waiting to be hit by something and become neuroblastoma, basically, right? So those are the questions that we really don't know the answers to. And this paper tries to look at that. So this is a graph from the figure. Now you guys can really understand what these are. I'm going to tell you what the columns are. The columns are basically tumor samples that they looked at. Those on the upper part, the chapters, basically. So every dot that you see here, the black dots, represents whether the copy number of that chapter for that tumor is gained. So it says 17Q gain. Q and P basically are beginning or the end of the chapter. So basically the 17Q means the end of the chapter is gained. 17 gain means the entire chapter is gained. So there's a lot of variability, but as you could see, there's some common themes. So about 96% of the samples have traditional chapters that are gained or lost within this sequence. So 17Q, 1Q gain, 2P, 2 gain as well. We see a lot of these repeating themes of the chapters being lost or gained in neuroblastoma. At the bottom part is these passages of the genes that I mentioned, and their changes in their spellings, basically, and there could be different types of spellings that could occur in different parts of the passages, but those are the mutations that occur, and I won't worry about the alterations, but that's basically synonymous to whether you're reading the entire protein and part of it gets deleted because of the alternative spelling or what happens. But there's, again, a little bit more of a paucity of the mutations that occur in the bottom part, but they're still there. And then the last part that says TMM all the way at the bottom, basically that's the telomere maintenance machinery, and that's, or mechanism, that's the binding that I told you. So that these cancers, if they're really good at maintaining their bindings for the chapters, it's denoted as red, basically there. And then there's also stage 1, 2, 4S, stage 3, and stage 4 disease all the way on top. So what they try to do is they look at this, this is one particular tumor, and the diagram that you see basically, that you see black dots across and or green dots all the way on top, this again goes the same idea. There's different chapters for a particular tumor, and for example in here, the chapter 1, the latter part of the chapter is gained in that green part, versus there's parts of chapters that are normal in copy number 1, and then other ones are deleted or lost. But we could actually look at each part of these chapters and measure the alternative spellings that occurs in these things to get an idea of how old this book is And what they actually found very interestingly, found that among the cells, you could tell that there's alternative spellings that are across all the samples, meaning that they originated from a really early progenitor cell. And then there's somehow early on, there are changes that occurred in some of the chapters that gave rise to neuroblastoma. And that's basically showing this 2 clonal copies. There's 2 copies of this that has an increased frequency of these alterations. And that's basically denoted down here as how this evolution occurs. But they're basically saying that there's 2 types of neuroblastoma progenitors that you could see. There's one that is a early common ancestor and then the most recent common ancestors. And they go on to nicely show, that in neuroblastomas that you could see, there's types of neuroblastomas that have this early, most recent common ancestor cells, and there's types of tumors that have both this early and the most recent, and there's few of them that actually have no early common ancestor. What that translated into actually is survival as well. The tumors that had just the early, most common recent ancestor have the ones that didn't have this binding capability of keeping the chapters, so they didn't have the TMM, the maintenance of the telomeres, and they had an excellent outcome. Versus the ones that had both the early common ancestor or most common recent ancestor had actually worse prognosis. And there were ones that had the 17q gains and this ability to maintain their chapters really well. So then they did some fancy mathematical modeling to basically show that if you think of this as the early common ancestor occurring, staying quiescent, and then gaining some abnormalities later on in life, what would be based on the incidence of 1 in basically 100,000 children, and then computing the number of mutations that could occur and how often these cells turn over, and oncogenic events, they estimate that this early common ancestor occurs in the late first trimester of pregnancy. So there's something that happens and not all of those become high risk, right? Because a lot of them do become basically what we think these neuroblastomas in situ, and they go away. But this is the first telltale sign. So this definitely requires further validation. And we could think about looking at even single cell fetal tissue, aborted fetal tissue, to look at this thing to see whether we could see these alterations in these single cell analyses. And they're doing a large study in Germany on additional tumors to validate this finding. But this is sort of the first clue that we're getting that maybe some of these early events that occur really early on. Why they occur, we do not know. All right. So I'm going to change a little bit gear towards what I actually spend a lot of my time on, which is inflammation, cancer immunotherapy, and trying to figure it out. I'll give you guys a little bit more of a introduction to what I call a tumor microenvironment as well. So in order for the cancer to actually evolve and get larger, it needs to evade our immune system. As we get older, have cells that become tumorigenic all the time. We don't realize it, and our immune systems actually take care of it without us knowing. That's why a majority of the people who get lymphomas or other cancers are the elderly, because our immune system gets weaker. So once the tumor occurs, a small tumor, just few cells, what happens is that it goes back and forth, the immune cells comes in, the NK cells come in, and they kill it because the tumors are producing these abnormal proteins, and they recognize and they're killed. And there's some things also intrinsic. If they don't have their maintenance, the telomere maintenance ability, they also devolve and die off. And we think that's one of the reasons why the stage 4S tumors as well, or these neuroblastoma in situs, go away, is because they don't have that ability to maintain their telomeres. So at some point, again, this occurs, the tumors get eliminated through either the NK cells. There's also this dormancy, we believe, that occurs, and there's a lot of evidence that shows that this does occur, where the tumor remains dormant and it's like I will not grow and the immune system will not kill me, I'll stay there, until an event occurs again that then the tumor cells get the ability to hide away from the immune system. The immune system no longer is able to keep it at bay, and they produce different proteins that again shut down the immune system. One of those proteins is called TGF-beta, arginine that Dr. Goldsmith talked about as well. All of those things come into play when the tumors escape the immune system. So our interest, my interest in the lab many years ago, was to figure out why children who have a metastatic disease that are less than 18 months of age do so well with just few cycles of chemotherapy versus the kids who are older than 18 months for MYC non-amplified subtype do so poorly despite giving chemotherapy and transplant. And one reason is basically they do have a different genomics. So again, the younger ones have the whole chromosomes, whole chapters amplified or deleted, versus the younger ones have this abnormality in terms of the tumors have this abnormality in terms of deleting certain passages as well. So we looked at a lot of these tumors, and what we found out basically is that it's a fancy figure, but each row of that upper, what we call a heat map, denotes the expression of the level of the Legos or proteins that are made in those tumors. Each column is a tumor. And then they're sorted by age at diagnosis. These are all metastatic, children with metastatic neuroblastoma. And as you can see, right after around 18 months of age, there's a lot more red on the right-hand side than there's on the left-hand side. And these are proteins that basically look to be related to inflammation. So somehow the tumor gets inflamed, lots of immune cells come in. And when we look at it on a microscope, we actually saw that the tumors that come into the tumor, the immune cells that come into the tumor are these cells that we call macrophages. And they play a big role in supporting the immune cells I'll talk about in a second. But we actually built a predictor to figure out for the kids that are older than 18 months whether this inflammation, along with some other tumor markers, denotes a worse prognosis or a better prognosis for certain patients. And we developed this high-risk, low-risk category for the patients. Going back to the macrophages, these are immune cells that are always in our blood, and they have two functions. One is they become into macrophages, and the macrophages either engulf bacteria and have anti-tumor effects, or there's these M2 macrophages. When you cut yourself or you get injured, these macrophages come in and try to heal your body. So the macrophages that come into the tumor are similar to the M2 macrophages. They're actually trying to help you. So whenever you get chemotherapy and you damage a neuroblastoma, what next happens is that a lot of monocytes come in and try to actually heal the tumor. The body doesn't, again, recognize this as a foreign part of the body. So a lot of our efforts are into figuring out how to actually block the effects of our immune system, helping the tumor in these cases. We'll go a little bit more quickly through this, but we have a mouse model of neuroblastoma, and we actually see this as the neuroblastoma develops. This does happen. The macrophages in brown, these are all cells that on top, and the top is just a normal adrenal gland, and the bottom one is a neuroblastoma that's developing. You see all those brown spots are macrophages that come in, and when you put macrophages together with the tumor cells, they actually grow faster. So long story short, this basically interaction between macrophages and neuroblastomas has a lot of communication. The tumor cells tell the monocytes, hey, come into my area. They produce a lot of proteins, including TGF-beta, and that leads to the growth of the tumor cells through amplification or increasing regulation of the MYC. We've also recently found out that there's other cells that supporting structures called fibroblasts, together with neuroblastomas, also produce a lot of this TGF-beta that we think actually promotes not only the tumor growth and evasion, but we're also seeing that they actually help maintain some of those early progenitors that I mentioned to you, the mesenchymal type of tumor cells. So after chemotherapy, when the macrophages come in, they're actually helping regenerate or induce the expression of proteins that are of these neuroblastomas that give rise to more neuroblastoma. And the TGF-beta itself keeps the T cells away, and including CAR T cells. So this is really a major issue. So a complex figure with a tumor cell, NK cells, CAR T cells, these MDS or macrophages are what I'm talking about. They're all trying to get rid of, push the T cells out of the way and producing these various proteins. I'll talk a little bit about CAR T cells now. Briefly, just to give you the challenges that we have in CAR T cells, I know you heard it from Dr. Hexey yesterday and Dr. Goldsmith a little bit. I'm going to give you a little bit just a big principles on how we are trying to tackle this thing. CAR T cells, as you guys know, it's a regular T cell that you get out of the blood. You again engineer that DNA to make a chimeric. Chimeric is basically a half of two different animals, and we're making new Lego pieces, right, that we put on top of the T cells. And the purpose of this new built machinery, a new protein, is to be able to go and bind to the tumor cell and kill it. We grow these things in billions outside the body, and we give basically 500 million to 1 billion cells back to the patient, and it works beautifully in leukemia. And the reason it works really nicely in leukemia is because as you infuse these CAR T cells back to the blood, the first thing that they see is leukemia cells running around the blood, because that's a blood cancer. But you could think of neuroblastoma and a solid tumor. What happens, these solid tumors produce that TGF-beta that I told you as a cooperation with macrophages, and the TGF-beta basically disables the T cells. And also when you inject 500 million or 1 billion cells into a patient, they have to find their way into the tumor and then set up shop and grow and try to kill the tumor. That's a very hostile territory they're going into, and there's not enough CAR T cells. So one of the main challenges in the CAR T cell is how do we create a more hospitable area for the CAR T cells to do their job? And this is a research that I'm focusing on, and hopefully in a year or so I can tell you guys that we're starting a clinical trial on a new chimeric that we've developed to help offset the effects of the TME with CAR T cells. The other challenge in CAR T cells is off-tumor toxicity. So some of these proteins that we're going after, GD2, as you guys remember, are also present in the normal nervous system and also in our central nervous system tumors. So we did an experiment where we tried to make a really, really good GD2 CAR T cell for a mouse neuroblastoma. Highly effective. And then one that, actually we didn't know, and one that was not as effective. So basically these mice on the left-hand side, they continued to develop the tumor, and one of them got cured, but a lot of them died due to the tumor, versus the really good CAR actually infiltrated into the CNS, into the brain of the mice, and actually killed the mice. So we don't want that as well. So we have to figure out ways to make these CAR T cells also safe. And one way we thought about this thing is to have, again, a complex figure, but having a dual approach. So basically you could do this as a dual CAR T cells. You could attack two antigens or two proteins on the tumor cells. Or you could have this what's called a gated CAR T cell, where you basically send a sonar, and the sonar says, yes, there's a tumor nearby, get the torpedo ready. And that's the concept basically that we went after. So you have to have both of the markers on the tumors before it kills the tumor. And we were very successful in this approach, and this is another approach that we're taking as well, where we have these B7-H3 CAR T cells that cure the tumor, but we wanted to make this gated approach. And again, it's a fancy picture for that same thing, a sonar technology that actually activates, when you see the GD2 on a neuroblastoma, it activates the B7-H3, and it primes it to actually bring the B7-H3 out to kill the neuroblastoma tumor cell. And this approach has worked really well for us, again, in our animal models, showing that we could actually go ahead and create these B7-H3 GD2 or GD2 B7-H3 CAR T cells. And even though some of the CAR T cells actually may get into the brain, animals do not die because the sonar is shut off back then and the CAR T cell stops functioning. So these are the two challenges that I mentioned, and my lab is very active in this pursuit. So in conclusions, basically advances in single-cell technologies that where we go and really read the data from all these cells will help us identify the origins of neuroblastoma tumors. Understanding the tumor microenvironment, the macrophages, the fibroblasts, how they interact with the tumor cells are really important to think about new opportunities to improve our combination therapies with immunotherapies. And the CAR T cells are really exciting to me, and hopefully in a year or so I could come back here and tell you guys about a clinical trial that we're going to start with these CAR T cells. But there are definitely challenges. Again, thank you. Thank you for all your participation in the clinical trials, and a lot of the people who've helped me, including family foundations, to get my career going initially and help me continue to do the research in neuroblastoma.
Thank
Happy to
you.
take any questions.
Anyone have any questions? No, you got them this time. Oh, okay. Kate's got one. We've got one here.
I'm so fascinated. Thank you so much for explaining that as chapters of a book. That was really helpful. And it's just a really people-friendly way to understand genetics. So thank you. I wanted to start with that. But I wanted to ask, when you're examining these genetic sequences and you're coming upon these genes that we know are affected by neuroblastoma, first of all, are you able to kind of see which book this comes from, right? There's mom's book and dad's book, and does that genetic code play any, does that help at all to examine genetic sequences or family? I know neuroblastoma is not like a family history disease, but does it help in the research to identify, and are there related conditions on the same genes? Things like that help.
You mean in terms of how the neuroblastoma was formed initially?
Yeah,
As
or
well?
does that make a difference? Does it?
It
seem
does.
to
I
matter?
mean, there's a long. I come back from I got my interest in science looking at Lou Gehrig's disease and ALS, and there was a familial cause of ALS, and we looked at a lot of genes and be able to figure out why it caused Lou Gehrig's disease. So John Maris, and I helped slightly in this project as well. Long ago, we tried to look at a lot of neuroblastomas and tried to look at a lot of the genes to see whether the normal genetic of a child predisposes them to neuroblastoma. And what we found is there are certain genes that may predispose, but the effect size is so small. And by effect size, I mean, you take cigarette smoking, right? If you smoke a pack of cigarette for 10 years, you have 8 to 10-fold higher risk in population, actually sometimes more, 20-fold, to get a lung cancer, right? When we see these genetic alterations, these alternative spellings in children's blood that we say predisposes to neuroblastoma, the incidence, the risk of developing neuroblastoma, it's like 1.5 times higher than population. So we can't for certainly say that the child will develop, but it does give us an insight into the biology of neuroblastoma. So that paper basically says that there is something that happens, right? The second trigger is unknown still, and it may just go its course and evolve and then get smaller again and regress in the first year of life, which majority of neuroblastomas do. But what keeps that second hit and when that occurs is unknown.
Okay, one question back there.
Hi. Yes, thank you for kind of putting a lot of this in layman's terms, right? Like the explanation of some of those challenges with CAR T, with solid tumors versus a blood cancer like leukemia. If a patient goes into a CAR T with a lot of marrow disease, would that, I mean, obviously we have the challenges with solid tumors, those clusters of cells, things like that. But would marrow disease with neuroblastoma would you expect a similar outcome like as a leukemia that's like those free-floating cells? Would that, I guess, how does that correlate? Is that?
Good question. So it will be a harder challenge in bulky tumors in general, right? But if you're talking about if you have a child that's relapsed that has smaller bone marrow metastases or bone metastases all over, which is typical what we see. We don't see a giant bulky tumor because we do a lot of testing, CT scans, MRI scans, MIBG scans. I think it does give you an advantage over a bulky disease. In animals, if you have a large bulky disease, especially for neuroblastoma, interestingly, compared to other solid tumors, there's a lot of interaction that causes, as we discussed a little bit yesterday, some CRS syndromes, even in mice. But the challenges with the TME remains the same. So in the bone marrow still, there is a microenvironment niche that helps protect the immune cells, tumor cells from the immune cells. So you still have to overcome that barrier. You may have a little bit of a less of a challenge in terms of the circulation and getting to that place compared to actually a bulky tumor. But the TME challenge still remains the same. But we have to test it, That's what the goal is,
Right. Thank you so much.
certainly.
Okay, another question?
Hello. In regards to the T-cell approach, I understand the challenges with T-cells has been persistent and expansion. Are you in a position right now to disclose is that still a challenge? Has Rome overcome that?
Yeah, very good question. You know, again, you think about number games. You know, the reason we give chemotherapy and this called lymphodepletion chemotherapy before every CAR T cell is because typically in our body there's billions of cells, or 50 billion white blood cells, no, to 200 billion white blood cells running around our body. And the reason we give lymphodepletion is to decrease this number to allow the expansion of the CAR T cells that we give the patients. And the amount of CAR T cells we give the patients, typically around 500 million to 1 billion cells, right? Some with billions probably a little bit higher end. And to allow them to expand. So it turns out that for most of the CAR T cells that we have, they expand up to about 100 cells per microliter, for around 2 weeks, and then they go down. And that's a big issue in terms of expansion. So the way we're approaching it with the construct that I didn't really go into detail is we're using TGF-beta that the tumors secrete as a way to also expand our cells in the blood. So that the CAR T cells that we're constructing, I'm happy to disclose this, basically uses that TGF-beta and reverses it in the T cells, allows them to expand, which the TGF-beta actually in a lot of the patients with neuroblastoma at relapse is higher than normal individuals. So we could expand it, and then once they get to the tumor, there's a lot of TGF-beta as well there, and that will aid them in doing their job, which is killing. So expansion is a big issue. You don't want it to be huge, because then you'll cause problems as well, the CRS and a lot of other things, and off-target toxicity. So we have to figure out the therapeutic range that we want to do this.
And persistence?
So the persistence, again, is for me, is also tied to the using the tumor microenvironment. If you eliminate the tumor, you eliminate the proteins that are secreted that maintain that environment, then your CAR T cells will get lower in number. But for all these CAR T cells, there's importance of also putting in a suicide gene, basically, that you could activate in case there's problems.
Thank you.
Sure.
Hey, anyone else? Any other questions? Okay. Thank you.
Of course.
We're going to go ahead and take a 15-minute break, so be back here by 11:05.
Yeah, no, I'll be. Yeah, but, and my slides will be, my slides don't say anything, but they'll show up here.
Yeah.
Cool.
Yeah.
So it could help in the neuroblastoma if you like say if a parent had help and they knew it
Okay, we're going to go ahead and get started. Our next speaker is Dr. Valerie Brown. Dr. Brown is a professor of pediatrics in the Division of Pediatric Hematology Oncology and Stem Cell Transplant at Penn State University at Hershey Medical Center. She received her bachelor's degree at MIT and PhD and MD at the University of Pennsylvania Perelman School of Medicine. She also did her residency and fellowship at CHOP. She serves on numerous committees and boards related to neuroblastoma and other childhood cancers. She instituted and leads the clinical program, experimental therapeutics, research, and clinical team. She has lectured at many programs throughout the country as well, and her talk today is on the current trials at BEAT-NB. Dr. Valerie Brown.
Okay, let me see. First of all, let me get this thing working. I'm notorious for hitting the mic with a hand that starts to flail because I tend to get overexcited because I love science and I love medicine. So much so, just as a quick story, when I had a lab when I was back at CHOP. And by the way, I'm not a neuroblastoma expert. You're like, why the hell is she even here if she's not? But Giselle Scholler, who's the leader of the Beat Childhood Cancer Research Consortium, was unable to attend. And she actually asked me if I would step in her place to give you updates about our consortium, to which I'm a member. But this was back at CHOP, so this was over 10, 15 years ago. My nephew, who now is an resident in pediatrics and genetics at Cincinnati Children's, was working in the lab over the summer, and I had in my office, he was there, one of the technicians was there, and we were talking about one of the pathways we were studying in leukemia, and I was getting really very excited, and I just blurted out, "Don't you just love science?" Like that. And I thought they would respond like, "Yeah, we love it too." That's not how they responded. They looked at me like I was crazy, and it was just dead silence in my office. And I'm like, okay, and they're like, yeah, I guess we love it, maybe not as much as you do, you know. Next thing I know, I walked into the lab a few hours later. Wouldn't you know it, on the whiteboard, it says, in quotes, "Don't you love science, Val Brown." And that lived in there forever. So I apologize if I get very excited, but this is just something I just think is, in general, is just so fascinating. And remember, data don't lie. People may misinterpret data, but the data are the data. And that was just a tenet I was raised on professionally. And despite being at CHOP for training there and being there as an attending in their blood and marrow and cellular therapy program, I wasn't really part of the neuroblastoma team, but I certainly felt like it because it permeated our division there. Anyway, enough of that. Now that gives me time to figure out, okay, I got this to work. So I really have no conflict of interest statement other than to say I'm the poor substitute for Giselle, who really sends her regrets for not being able to attend. And Pat, again, if I get overly excited, please do something to reel me in and stop me. Okay? All right. So these are the things that Giselle wanted me to cover in this talk. The first was basically to give an update about BCC's consortium, because it's, spoiler alert, it's moving to Penn State. And I am over the moon about that. Then I'll give you an update about our DFMO program. And I do apologize if I say DMSO instead of DFMO, but here's a little fact. DSMO is the preservative we use to preserve stem cells, hematopoietic stem cells. So I'm always used to saying DSMO, not necessarily DFMO. So sorry about that. And then I'm going to talk a little bit about our precision medicine program, which was touched on in the previous two talks. And actually, a parent brought up a very good question, like, why aren't we doing this for everyone? And I agree. It should be done for everyone. Then I'm just going to give you a quick overviews of our two protocols that we currently have open, but recently opened, that I think are very exciting. So first of all, Beat Childhood Cancer Research Consortium, which I'm just going to call BCC now for brevity, it is a very large conglomeration of institutions across the United States and North America. And I'm sorry if the print is really small, but it lists all of them there. And the headquarters for BCC, until very, very recently, was in North Carolina at Atrium. But, as I said, spoiler alert, it's moving to Penn State Hershey. So we're very excited to partner with BCC. So Dr. Schuller is going to be moving to our institution and will be our division chief, but she's bringing BCC with her. So this is a slide to remind me that it takes a village, it takes a village to run a consortium like this, and the names that are listed here, which I can barely see because I'm too old to focus on the confidence monitor here, but Giselle, obviously, oh, thank you. Giselle's, he just made it bigger. Giselle is our fearless leader. The clinical program director is Genevieve Bergendahl. Our program manager is Abby Moore, and there's a host of other people that make this consortium run the way it runs. And how many in the room have interacted with BCC? Before I go any further. Okay, we got a couple. That's cool. So what is BCC, other than this collection of organizations across North America? Well, I think of it really as we have two major focuses. The one focus is development of clinical trials, and specifically developing novel therapies and testing those novel therapies through clinical trials for patients that have difficult to treat relapsed and refractory pediatric or childhood cancers. The other big piece of what drives us in BCC is precision medicine, which is a little bit what was alluded to one of the questions at the previous talk before the break. And so we are so ingrained in giving a tumor a name, giving it the diagnosis, either based on location of that tumor or what it looks like under the microscope. We call that morphology. But we're learning more and more that if we classify those tumors or treat those tumors based on the molecular interrogation, so not just what the genetic alterations are, but what are the protein alterations, expression levels, what's going on in the tumor microenvironment. If we take that approach to the treatment of the individual, we will probably be more successful in treating that patient. That's sort of the ultimate goal. And, you know, when I first, so I'm really old. I've been an attending now for over 20 years, oh God. When I first heard of this, 15 years ago, 10 years ago at AACR meetings, American Association of Cancer Research, it was really like a pipe dream. And to see this evolve so much over the past 20 years where we're doing this, it's phenomenal. And it will change the face of the outcomes for not just pediatric cancer, but adult cancers too. That's just an editorial. That's just Val's opinion. So one of the major efforts for BCC has been focusing on DFMO. And here is a laundry list of what those efforts have looked like. It started back in 2010. This was even before I joined BCC. It wasn't even called BCC back then. In 2010, there was an initial phase 1 trial using just DFMO alone. And from that very small trial, there are, I should say, long-term survivors from that study who were only treated with DFM alone. Actually, and one of them is about to start college. That led to a series of phase 2 trials, some that have been completed, others that are ongoing, that are listed in the next few bullet points. So, and the one that I will be talking about in the next couple of slides is a phase 2 trial of DFMO that's used as maintenance therapy. And I'll define better what I mean by maintenance therapy. in children with neuroblastoma. We also have a ongoing phase 2 trial with DFMO that's studying dosing. Does dosing matter? And what impact that has of a standard versus high dosing. We also have a phase 2 trial that is combining DFMO with another old-time chemotherapeutic called etoposide, where you get 6 months of etoposide and then with DFMO, and then you get 18 months more of just DFMO as single therapy. We have a study called the PLAN study. I don't know when it became the PLAN study. It was always PEDS plan, but whatever, which has a randomized component to it. And thank God for the speakers yesterday and today, because I don't have to necessarily explain all those terms. But if there's something you don't understand, stop me and ask me, okay? Because I get on a roll and I get excited, so I apologize. So there's a randomized component to that trial where you get standard high-risk neuroblastoma therapy, and then at the time you're to begin what we call that maintenance immunotherapy with retinoic acid, patients are then randomized to receive DFMO during that immunotherapy or not just during that period, but all patients then receive the 2 years of maintenance therapy. That's the PEDS plan. It also had a component that had to do with molecularly guided therapy that was done in the beginning of induction, but we completed that enrollment, and we're still analyzing that portion of the data. So this is the part B of that study. We also just weren't focusing on neuroblastoma because you'll see in a few slides, really you want to look at mechanism and you want to see what there are other tumor types that potentially would be vulnerable to the inhibition that can be caused by DFMO. And one of those tumor types is high-risk medulloblastoma, which is a type of brain tumor that is not easily treated, at least when it's high risk. And if your tumor looks like it would benefit from being treated with DFMO, we do have, it's essentially an expanded access protocol that is available for those who wouldn't qualify for the other studies that we have there. And that one was originally only available at Atrium in Charlotte, but that is now transferring up to us at Penn State. So here's the question. I mean, I remember asking this when I first joined the consortium back 2011, 2012, like, why DFMO, right? We heard a little bit about that from Dr. Goldsmith, but again, I think that it really behooves us to understand the fundamentals first, because if you understand better the fundamentals of normal cell growth development, then you'll be able to understand better the cancer biology. And that gives you better insight to how can you create more targeted therapies and actually even anticipate what would be some of the potential side effects of these targeted agents, because they do have what we call off-target effects, meaning it's affecting cells that are not the cancer cells. And it just gives you insight to the whole picture. And plus, I honest to God think that it's absolutely miraculous that you take a sperm, you take an egg, you put those together, you make one cell, and 9 months later, you end up with what we would call a human, a baby, right? That hopefully has 10 toes, 10 fingers, etc. And the only way that can get accomplished is by a highly regulated program of development. And we've seen things when sometimes that program goes awry. Sometimes a person's born with 6 fingers on a hand, not 5, etc. May not be the end of the world, but that's when the program has gone awry. Because the body has systems where it's going to turn things on, turn things off. That's how you can differentiate, right? Because remember, everything came from one cell that, as we heard earlier, had 2 copies of that DNA program. And that program has to get replicated over and over, and yet genes that are turned on and off have to occur so that you end up with that fully developed person with a relatively fully developed immune system at the end of 9 months. It's really surprising that it doesn't go wrong more often. But our bodies have a lot of checks and balances to counteract when things go wrong, and when and also to make sure it goes correct. And then once you've sort of developed those, then you have to maintain those cells. But you have to have a balance. So I'm an immunologist too, so we call this homeostasis. There's the balance. You want to have a robust, immediate immune response, but then you want it to go back to normal. You don't want it to overshoot and then cause problems. It's all about balance. And that's really what your normal cells are doing. They're going through a balance of having enough nutrients or fuel, we call that the sugars, to simplify it, the energy to make a new cell or perform the functions that it's supposed to, and also provide the building blocks if it's going to build a new cell. It has to have those amino acids, it has to have the nucleic acids to build that new cell. With dormancy, because not all those cells have to be really active or metabolically active all the time. You need a few that are kind of like resting, call me when you need me, you know, kind of thing. And like if something gets injured, these cells will then kick in, they will wake up and start to differentiate and replace whatever it was that needed to take its place. Or like if you're going through puberty, there's a bunch of cells that were laying dormant that will wake up, start a new program, and allow you to develop what we call the secondary sex characteristics that we call puberty. Do you follow all that? So that's sort of the normal, what happens. So now we have a cancer cell, right? And the way I look at this, and this is very simplified and took decades of research to come up with these concepts. But a cancer cell, generally, requires a lot more fuel or energy to survive, because very often it is dividing more frequently and helping to build new blood vessels so it can get oxygen to survive, because if a cell has oxygen, it actually can produce its fuel more efficiently than just burning off glucose. And it also needs a lot of those building blocks. It needs the supply materials in order to build those new cells. And what it will do is very often it will hijack those normal cell functions to give itself a survival advantage. And so the things I have listed there in the smaller bullet points are examples of that hijacking that can occur. And so sometimes a cancer cell will only use one or two of those mechanisms. Sometimes it uses all of them simultaneously. Sometimes it'll do it in series. But it senses what's going on around in its environment in order to make sure that it has a high enough supply of energy and the building blocks to do its job, which is to build a tumor, which is really not helping the human body as a whole. Okay? And so it can do that by changing the regulation of its cellular metabolism or how it utilizes or generates its energy to meet up with its new energy needs. It can actually even eat parts of itself. It's through a mechanism called autophagy, where it will eat up some of those proteins and recycle the amino acids that make up those proteins to make other proteins that will help to maintain that survival and growth of the cancer cell. Sometimes it can eat itself too much, and it can die that way, and we can leverage that for a treatment. It needs to hijack the way a normal cell or organ will develop blood vessels so that it can make sure that there's a sufficient oxygen supply delivered to the tumor. Sometimes tumors grow so rapidly and they haven't built in those blood vessels that if you were to take that tumor out, it's dead in the middle. It's because it didn't get enough oxygen. It sort of starved itself. And we heard a little bit about this in some of the other talks. The cancer cell can sort of send out parts of itself to migrate to other parts of the body, where I think of it as kind of tilling the soil or preparing the soil in other locations in the body to create metastatic disease. The other way it can hijack the immune system, or the normal function, is to sort of hijack the immune system. And the easiest way I can put this, or one of the most common ways, is making a Harry Potter analogy. And the cancer cell will put an invisibility cloak on itself, and it won't be seen by the immune system. The immune system just passes it by. Or the immune system has seen it so many times, it's like, well, wait, maybe I made a mistake and I'm not supposed to attack this, and lets it go. That's the tumor evasion that was talked about earlier. So if we really understand better all these different mechanisms, then we will be able to develop more effective therapies that can block or reverse these processes and stop these cancer cells from growing, kill those cancer cells, and perhaps even wake up the immune system. All right, everybody still with me? Okay, I see some heads nodding. It's okay to say no. This also concept was a little bit touched on earlier. A cancer tumor is not, the cells that make that up are not all the same. There's heterogeneity in that, innately in that. And just like in a lot of our normal organs, we have cells, they can be referred to as cancer stem cells, that are the ones that are dormant, lying in wait, and if there's a trigger that will wake them up, to then go on and differentiate into a new cancer cell. And that's often a mechanism that causes a relapse. And the reason that those cells survive it is they are just not as vulnerable to being killed off by our conventional or current chemotherapy and radiation treatments. So all right, I'm gonna see what this thing does. Is it the spot? Oh, geez. Okay, sorry about it's a spotlight, because you can't really see it on here. Well, anyway, the top half of that slide, you give your chemotherapy, you get unspecific killing, and the tumor will shrink. But yet, there's one cell, or a population of cells that survive, which is those ones that can undergo self-renewal, and it takes some time, and there can be another trigger that causes that to happen. Then we'll grow up, and in very simple terms, it would be the relapse. However, if you treat the tumor with more targeted therapy and targeting to kill those stem cells off too, then the tumor will shrink and then regresses, and you don't get that relapse. Very, very simple simplification of the whole process. But these are sort of the things, the fundamentals you keep in your mind when you're trying to develop more targeted therapies. So, all right, how does this go back to neuroblastoma? Because I know that's what I'd be asking next. And DFMO. So we heard about ODC, which is an enzyme that promotes cell proliferation and will help to supply the cell of its required nutrients. And ODC is often elevated in high-risk neuroblastoma, and it's been shown that outcomes are worse in patients that have elevated ODC levels. So you can imagine it if we block the ODC with something like DFMO, then it actually will decrease that glycolytic metabolism. So glycolytic means sugar metabolism. That's the fuel. You're helping to cut off the fuel supply. And as we heard earlier, Dr. Goldsmith had talked about how it can influence the milieu of your immune system. Well, it also does another thing at a cellular level that becomes important when we talk about that stemness or that ability to self-renew. And there's a pathway. So remember, normal cells, there's a lot of checks and balances to keep things in place. So there's this thing, it's called the LIN2BA, or LIN228B, and LET7 axis. And if you have that seesaw leaning towards an excess of LIN28B, then you have increased glycolytic activity or increased fuel production and a maintenance of that stem-like properties. But if LET7, sorry, I am failing my eye test big time right now. LET7 is in excess, then it is pushing things so that LIN28B is not as active. So you have decreased fuel production and a lack of stemness. Well, it turns out that MIC-N helps to push this seesaw towards Lin28B. But if you treat a cell with DFMO, it counteracts that and pushes the C cell more towards the LET7, which is the direction we want it to go. And that is why we say, yeah, DFMO is great for, you know, high-risk neuroblastoma because of the association with ODC, but you can see that now this drug would probably be effective in other cancer types that are affected by that Lin28B LET7 axis. So it's not just a one-shopper. And again, this is illustrating it's not just all about the morphology. It's really about the molecular makeup of that cell and what makes that cancer cell tick and survive beyond its neighbors, the normal tissues. So this leads me to the discussion of a phase 2 DFMO trial that was really based on, we're really trying to mop up any residual cancer cells after you've been treated and try to eliminate those cancer stem cells that are waiting and being dormant that would pop up in the future, potentially causing those relapses that survived the scorch and burn treatment that all of our high-risk neuroblastoma patients had to go through, okay? So the hypothesis was that if we use DFMO and start treatment at the end of immunotherapy, so again, I'm going to use this thing, it's not really, oh, it's not going to really work, but if they go through what we would say standard of care treatment for high-risk neuroblastoma, and usually then you're done when you finish the immunotherapy with, you know, anti-GG2 antibody, retinoic acid. But instead, what if then, if the patient's in a clinical remission, remember, remission is different than a cure. The definition of remission means we just can't detect it. Does not mean that those cancer cells are not there. That would be a cure, that the cancer cells are no longer there. And the degree that we can say you're in a remission varies cancer type by cancer type, and also as our technology evolves and our ability to detect things, okay? So patients were deemed to be in a remission, and then they could then start to receive DFMO, 750 milligrams twice per meter square, twice a day for 2 years. And the objectives or the outcome of that study was to see if we could improve the event-free survival and the overall survival actually after 2 years. So this was the results of a further analysis of this study, which actually I'm very happy to announce was just accepted by the Journal of Clinical Oncology. So it will be in press soon, but it's just a matter of tying up a few loose ends, but it has been accepted for publication. And the purpose really of this second look at these data was to make a comparison of what our results were from this DFMO study, which is what we call a single-arm study, which meant everyone who enrolled received DFMO, versus a randomized clinical trial where you flip a coin and you decide like what therapy you end up on. Typically, it's usually what's considered standard of care or the most accepted conventional chemotherapy versus whatever your experimental arm or arms are. But as we heard a lot about that yesterday, they can take a very long time to accrue, particularly if it's a rare tumor or subpopulation of patients that you're investigating, like high-risk neuroblastoma. And, you know, our patients can't wait. We can't wait 5-6 years for this to happen. And so you can use other controls for that population that did not get DFMO. In the past, often what we call historical controls were used, where patients that were somewhat treated like the patients that are treated on this study ahead of time before they enroll in this study versus not. And that's an okay way to make a comparison, but it's still not that golden standard of a randomized controlled trial, which some would also argue in tumors that are very rare, is that really equipoise? Meaning, is it really ethically fair? Because that, and we don't know if the arm is going to show a benefit or not, but all those patients that were on the randomized arm not to receive it didn't get that benefit, and it's an N of 1 for each individual subject enrolled versus we look at it as the whole study. But for the individual person, that's a big deal. That's a really big deal. So the royal we, not me, but the royal we, was able to work out an agreement with COG so that we were able to obtain the data that were collected on the 032 study, which we heard about yesterday. That was the pivotal anti-GD2 dinutuximab study that did change the outcomes of those patients. So that we could make a fair comparison, because if you just use historical controls, or getting back to the fruit analogy, you know, we heard about apples to, or oranges to oranges, then we heard about oranges to apples, and then oranges to broccoli. Okay, so that meaning they're really divergent. I would say without, initially what we're looking at is sort of oranges to tangelos, because right, tangelos are made from oranges and tangerines. Like, it's not quite as clear as an orange to an orange, but it's certainly not an orange to a broccoli, period, okay? And so the conduct of that, the COG study, that was all done independently of 003B. So there's not any influence in either one of those trials. It's basically making a comparison of those trials. So what happens when we do that? Oh, all right, so first, again, there's always outliers that are enrolled in a trial, and I'm sorry that this is really, really tiny. However, luckily I do remember what the numbers are. But there were originally, I think it was like 140 patients that were enrolled in the DFMO trial, okay, the maintenance trial. And of those 140, actually 87 of them participated on the 032 trial. So that's actually really good, because you know that those patients were all treated the same way, going in, those 87 patients. And there were actually an additional 5 that were treated like they were enrolled on that study, but the study had closed, but the primary oncologist had treated them as if they had enrolled. So they were included in the DFMO treated group. The non-treatment group, which is the 032 group, that actually had a number of patients that were not in a remission at the time when they were randomized to the antibody. And so we wanted to make that a more even comparison. So some patients were excluded from this next type of, were excluded from that analysis. But the bottom line is we still had, what, 852 patients that were considered to be in the no DFMO arm. So if we do the analysis in terms of event-free survival and overall survival of those that were on the 03B trial, versus those that did not receive DFMO. So the blue curve, DFMO, green curve, not DFMO. And the hash mark with the numbers above it was actually the 4-year event-free mark. So that means these patients, the starting time was the start of DFMO, which had to start like within 30 days of your completion of the 032 therapy. So that's sort of like the starting time. And then you got, if you're on the DFMO arm, you receive DFMO for 2 years. So it really, like if you just stopped at the 2-year mark, it's like, well, yeah, but what happens to these patients like after they're off DFMO, right? So that's why I'm presenting the data here with those marks at the 4-year event-free survival. So that's 4 years after the start of the study. What is the percentage of patients that were event-free, meaning they didn't relapse? And that's the panel that's on your left. And then the panel on the right is overall survival. So that's patients that maybe they did relapse and got another therapy, but are still alive. And you can see there's a difference in those two curves. And that difference between those two curves is statistically significant, both for event-free survival and overall survival. But there were still naysayers or skeptics, and I mean, I appreciate that, because there's bias in this. We're taking a retrospective trial as our randomized, or as our control population, comparing that to the DFMO population. So there's a statistical way, which I believe was recommended to us to do this by the FDA, that has precedent in some adult cancer trials, where you are using a different mechanism to devise that, or analyze, I should say, that control population, and has led to multiple approvals by the FDA for adult cancers. But this approach has not been used per se in the pediatric setting. However, what this is doing, it's called a propensity score match. And the way this is the way I think of it, if you took like all comers, and the data really weren't that different between what we call the no DFMO group and the DFMO group in terms of the demographics, like the age of diagnosis, some of the characteristics of their tumor, like NMIC amplification. In fact, there were more NMIC amplified tumors in the DFMO arm than the 032 arm. But if you were then to sort of subclassify those patients and do a more head-to-head comparison with patients like me, with certain characteristics, then you're kind of eliminating that bias that something was skewed to one end or the other, okay? So this on the left side lists the different characteristics that were used to sort of bucket these patients. And you can imagine, the more and more you're bucketing these patients, you're only getting a couple that meet all 12 or 11 criteria that are just like each other. However, we had only 90 patients on the DFMO arm to pair up with those from the no DFMO arm. But we had so many that we could actually take 3 of the no DFMO group and compare that to just one of the DFMO treated patients. And in doing that, that is enriching so that you're just not getting a one-off by just doing one-on-one. You're doing a 3-to-1 comparison. So that was done, and these are the curves. And guess what? I didn't go back and show you that first curve. This is the result of this. I mean, they are practically identical. The only difference is, I think, that, well, I can go back, can't I? Technology. So, of course, the DFMO curves are going to stay the same because that population didn't change. That's not being affected by the propensity or the pairing. It's the bottom curve. Does it switch the DFMO? Because that's what people were skeptical about, was that, well, if you really do this more head-to-head comparison, then that may wash out that difference between the two curves, but it didn't. It didn't. And it did it with multiple different iterations to look at this, and every time the curves look the same, essentially the same. They're not exactly, if you see it says 73, whoops, but if you go back to the previous one, it was, 74? I don't remember, but essentially it's the same. So what this tells us, and I'm sorry, I went the wrong way, and I think I still am. No, I just went really, yeah, I am. I'm so sorry. Nope. I don't know how I jumped like 20 slides ahead. I guess I got so excited I just started pushing the button. No, it's going why is it only going forward when I push that button? Oh, I see. Val, push the right button and you'll go the right direction. So simple concepts here. All right, I really apologize for this flash show, but there's the rest of the talk. But anyway, all right, so there are the curves. They are still statistically significant, the difference. So what does this mean? These data and this analysis suggests that DFMO-treated patients have half the risk of relapse compared to objectively selected and matched cohorts of external control patients that were from the 032 trial. And I didn't go over what a hazard ratio is because, that's another statistical term that sort of gives me hives. But really, it is saying that you can cut that risk down by half if you were to give them the 2 years of DFMO based on these data and this analysis. So this really was is the most robust findings to date that supports the meaningful benefit of DFMO as a maintenance therapy for the treatment of high-risk neuroblastoma following multimodal standard of care. Now, there are still limitations in a single-arm study, and that still can leave some uncertainty about the contribution of DFMO to this observed improved event-free and overall survival. But what you need to do is outweigh the risks of delivering this agent for 2 years. And I took this slide out for the purpose of time, but the profile of DFMO is pretty not toxic, especially compared to what your poor patients have gone through before this, and are manageable and reversible. So you have to weigh the risk of maybe having some of those effects to the potential of an increased overall survival. And so that's why we recommend recommend the incorporation of DFMO and upfront therapy as extended maintenance therapy in high-risk neuroblastoma. And unfortunately, I see that Pat's standing already, which is going to be a problem, because that really meant I covered 2 of the things I was going to cover. But if I can just say, because we've heard a lot about these other things, again, we feel you out there, and BCC is committed that all children, at least at the time of diagnosis and at the time of relapse, will get sequenced. Their tumors will get molecularly interrogated, because there is a definite benefit to that. And I could tell you a personal story about my sister regarding that, but maybe I'll tell you if you want to hear it over lunch. But we can learn so much more if we do this in large numbers. Because, as I said, each tumor is individual, but you do start to see patterns. And I threw this slide up not because it's just pretty, but that middle panel is, hundreds of patients. Each column represents a patient. It's a heat map. And the x-axis going downward is each gene. And it's basically showing a relationship of how overexpressed or underexpressed that particular gene is. But you can see there are patterns that show up, but not everything looks the same, even with the same tumor type. And that's where the individualized or the personalized precision oncology piece of it comes in and becomes important. And we're learning more and more, how can we identify those patients sooner rather than later in terms of how we're treating it. So that is a big initiative that BCC has taken on. And there's also a research aspect to that too, so that we can learn more in the laboratory about those individual patients, particularly those that are not responding as we predict they will, because why? What is different about them? And that is this precision medicine program, which I am now going to just go through slides, because you can I'm more than willing to talk about this. I'm here till tomorrow morning, talk to you about the details of that. The 2 trials that we have open, one is 017. It's a precision medicine and immunotherapy clinical trial. I'm only going to talk about the big 4 pieces of it. The first piece is you have your tumor biopsied, and you have what we call mobilized leukapheresis in order to get peripheral blood stem cells, and also to siphon off these special type of immune cells called dendritic cells, which are these things called antigen-presenting cells, which are the ones that are like presenting like antigen, which is a piece of a protein, to the rest of the immune system to say, hey, I found this. Like, I just gobbled up this piece like a virus. I'm popping this out on the cell surface. Maybe you should go find cells that are infected with this too and go kill it. Well, you can do that by loading those dendritic cells with the tumor RNA and basically forcing those dendritic cells, if you're a James Bond fan, like this would be M, right, his boss, James Bond's boss. So M is gathering this information. She's presenting it to 007, to James Bond, who are the killer T cells, and say, okay, now go, here's your mission, go and find them and kill them. So that's sort of the part 4, the immunotherapy part. But that takes time to manufacture those individually in the laboratory. So in the meantime, we've taken a piece of your tumor, we've sequenced your tumor, we've given you a round of, quote, like standard therapy to hold you off, because we know these tumors aren't going away for anyone. And then we give you cycles of the molecular guided therapy while we're waiting for the manufacturing of the vaccine. And then we end up hitting it again with hedging our bets, collecting T cells after they've seen the vaccine, because you think that you've skewed your T cell repertoire towards killing the tumor. And you're just enriching your immune system to have one purpose: go and kill any tumors. So that's, in a nutshell, this trial. And it's eligible, there's one arm for a brain tumor called DIPG that's newly diagnosed, and then this is the one you want to listen for, is a refractory or relapsed neuroblastoma patients. And some patients have already enrolled in this trial. There's more logistics to it. I'm not going to get into those. But there are a few patients that have enrolled, and again, this will take some time to do. The other trial, this will take 2 seconds, is 018, which is basically a phase 2 trial. It's an upfront neuroblastoma trial that's looking at the anti-GD2 antibody naxitamab being added to a backbone of standard induction therapy, a la like a trial that we heard about yesterday that actually is still in the works through COG, but using dinutuximab up front. This one uses naxitamab up front, and it is open and is enrolling. It's being open at more and more BCC sites, so it's not at all 60-plus sites, but it is open and enrolling, and it's really looking to see if we can improve the outcomes. So can we make a PR be a CR, partial response to a complete response, like at the end of that first block of therapy, induction therapy. And if patients are then, after consolidation, they could actually enroll to receive DFMO2 as a separate trial. But this is ongoing, and so perhaps maybe next year we'll have info. So that was it. I know, you're getting anxious over there. I'm really sorry.
Yeah, I don't mean to
No.
rush. It's just our next speaker has
Yep.
to leave very soon.
Okay, so, and there's our acknowledgements. Again, it takes a village to do this, but the one group that I need to highlight are the patients and the families, because without your generosity for allowing your patients, your sons and daughters, to participate in these studies, we couldn't get anywhere. And that, I can't even say that enough, how much I appreciate that. It does make a difference, so thank you very much.
My apologies. I don't mean to rush you. I'm so sorry.
Nope.
But if you want to have questions of Dr. Brown, we'll do them separately.
I'm here.
We have Dr. Kim Kramer that will be coming.
Yes,
She has
I'm
to
sorry.
leave and catch a flight. So our next, my apologies. I feel I feel terrible. But our next speaker is Dr. Kim Kramer. She's doing her self-introduction because I was very absent in not putting together her introduction. But I'll let her go ahead and tell you about herself. Dr. Kim Kramer from Sloan Kettering.
Thank you very much. It's very easy for me to give a boring, very boring background. I'm 5th generation from New York. Nobody from my family ever left the Bronx for 5 generations. And I am born and raised and trained all in New York, City University of New York, State University of New York, a little bit of time in upstate New York, which most people in New York City do not even consider to be New York. And I just got my 30-year pin from Sloan Kettering. But my biggest disclosure is on behalf of my team. We feel that taking care of you and your children is a sincere joy and a true privilege. So thank you Thank you, Pat, for inviting us to participate and to share just some of the things that we offer for children with neuroblastoma. So a few disclosures that outline some of the financial partnerships that MSK, some of my colleagues, and myself as consultants to YMABS have to disclose. Our major goals are twofold: to cure every patient with neuroblastoma, and that includes challenging situations, of course, patients with new diagnoses, but those that do not respond to what's considered standard of care, or those patients who have the disease come back after standard of care. And the other major goal, expecting that all of these children can be cured, the other major goal is to avoid side effects, and that comes by reducing exposure to conventional treatments, decreasing or not giving chemotherapy at all, or lowering the doses of radiation therapy. So this stems from the knowledge of many people here that have spoken yesterday and today, that there are striking contrasts in the prognosis and therapy. So it really is incumbent upon us to know who needs more therapy, such as the patients in the bottom for high-risk stage 4, who needs less therapy or maybe just surgery alone, or who needs absolutely no therapy at all. We had this approach to either not giving therapy or stopping therapy back in the 90s. And that was for patients that had non-stage 4 disease without that MYC amplified gene. So N0 were newly diagnosed patients that were never exposed to treatments, and STOP patients that were referred to us, and we thought it was safe to actually stop. And those N0 and N-STOP publications are listed here. So this no therapy plan does exist for patients even with stage 3 disease, and there are patients that have had incomplete or no resection, again, with the idea of avoiding injury to wherever the tumor may be. And that includes no therapy for patients that have favorable molecular findings. So our young babies that have stage 4 without MYC-N have an extremely high cure rate. We do not have any open formal studies at MSK for these patients, but that is because the low-dose COG and PSYOP chemo treatment is so successful. The bigger question is, how many cycles can you give, and can you avoid potential long-term toxicity? Can we limit the number of subsequent cycles of treatment, even in the setting of an MIBG scan, which still may be positive? And can we avoid no radiation therapy, no antibody therapy, and no surgery? Here's an example of a patient with infant stage 4. On the left, you see that every dark area is really neuroblastoma in the bones and the bone marrow. And then after low-dose chemotherapy treatment on the right, all of those dark areas have resolved. And just for parents who may not have seen MIBG scans, there'll always be uptake in the salivary glands on the sides and in the bladder. But as you see, it's remarkable how even just a little bit of chemotherapy can result in a clean MIBG scan. We've also expanded the definition of these babies with 4S that may have skeletal metastasis, and showing here that observation alone, these babies are still cured. So we know that in high-risk situations, neuroblastoma is chemosensitive, and it is responsive to drugs based on the dose intensity. So here again on the left is an MIBG scan of a patient that had neuroblastoma throughout all of the bones, and after 5 cycles, there's a clean MIBG scan, pretty much showing resolution of most of the areas of disease. So we know that we're dealing with a disease that really is chemosensitive. Now, to decrease the long-term side effects that we know many of these children have, we've recently started a pilot called N9. My colleague, Dr. Kushner, is the principal investigator. And the goal here is to see whether you can achieve the same cure, the same response rate with 4 cycles of chemotherapy. And the key thing to note here is that these 4 cycles have no cisplatin, which we know damages hearing, damages kidneys, and 1 cycle of a regimen containing doxorubicin, which we know has long-term effects on the heart. So this is an ongoing trial, 4 cycles. Stem cells are collected in the event that they may ever be needed. Radiation therapy is given, and then there's consolidation with the anti-GD2 antibody naxitamab and the bivalent vaccine, and I can go into more details on that. But the key thing here is that we are hoping that this trial addresses the drawbacks of our previous high-risk trial or the COG induction regimens. So the goal to decrease the ototoxicity, to reduce the cardiotoxicity, and to have flexibility in introducing immunotherapy. The lessons learned over the years from prior treatment for high-risk neuroblastoma are definite long-term effects to all of these organs that are listed here. Definitely ototoxicity, a risk of having a secondary cancer. We have an ongoing trial to decrease the amount of conventional radiation therapy that is given. That's led by our radiation oncologist, Dr. Walden, and using proton beam. And then we have the studies that have incorporated long-term anti-GD2 therapy. So we absolutely need people that specialize in survivorship and people that are specialized in taking care of our very young patients who we expect to grow up and move on with their lives. And the key focus for many of our survivorship specialists are to address long-term pulmonary toxicity, to really understand what are the secondary malignancies that are either malignant or the benign tumors that can affect our patients. For example, there's something in the bone that's called an osteochondroma. There's something in the liver we see on scans that's focal nodular hyperplasia. Neither of these are really cancers per se, but our survivorship is really trying to understand how often they affect our patients. And another goal is obviously to reduce the radiation-induced secondary neoplasms. So, immunotherapy regimens that target the GD2, which is on the surface of neuroblastoma cells, are many. For years, we used murine 3F8 that targets GD2, and then there was a switch to a humanized form that's called naxitamab, and you've heard plenty about the chimeric 1418 dinutuximab. Basically, these are all fantastic drugs that are going to target what we want, GD2. They tend to differ in the dosing or the schedule or the hospital stay or what kind of immune adjuvant is used to boost them, but they're all fantastic ways to target GD2. Here's an example of a response of neuroblastoma in the marrow with humanized 3F8. The 2 left panels show the dark spots, which are where the neuroblastoma was involved before, and then an MIBG scan showing resolution of the neuroblastoma after the naxitamab and GM-CSF. Now, this comes up a lot. There are many ways to consolidate patients, meaning to try to try to remove every single residual form of microscopic disease that could still be there after an induction chemotherapy. Years ago, high-dose chemotherapy with your own stem cells given back was a major feature of our program. And the publications with the results for high-risk neuroblastoma treated with chemotherapy and transplant are listed here. But over the years, we did not appreciate an improved survival if patients had upfront chemotherapy and consolidation with the anti-GD2 antibody. So transplant for us was really stopped in 2003. And over the years, the published reports included 170 patients with stage 4 disease that were treated with chemotherapy and antibody and not transplant. And this number of patients allowed for a robust multivariate statistical analysis. Recently, the team from Barcelona, without transplant, reported similar results. So this similar event-free survival and identical long-term survival for stage 4 patients and patients with localized MYC and amplified disease are included in the publications here. So moving on to vaccine, there's a way to construct a drug that can target GD2 and GD3 that's highly expressed in neuroblastoma. So this was constructed in the Chung lab, and the vaccine is typically given with other drugs that boost the immune system. So, you know, if you or I get a vaccine for whatever virus is out there, you have to hope that your immune system responds and recognizes it and makes antibodies that will protect you against whatever it is you're being vaccinated. Well, it's the same type of thing here. So this is our schema for patients that get the vaccine in first or second remission. It's basically 7 injections of the vaccine over 1 year, and it's given with the immune stimulant beta-glucan, which can be taken orally and stimulates the immune system. And the goal here is to achieve prolonged anti-neuroblastoma immunity by inducing patients to maintain their own anti-neuroblastoma antibodies over months to years. Dr. Irene Chung published the results of the progression-free survival and the overall survival for 102 patients treated in greater than second remission. So about a third of these patients had had multiple relapses with a 6-year progression-free survival of 32% and overall survival of 71%. The current vaccine trial at MSK is a randomization of getting the vaccine and the glucan and plus or minus the GM-CSF. And the goal here is to understand, do we need those additional shots? Is the GM-CSF that important? Does it really improve things? Or can it be the vaccine and the glucan alone? It also includes boosters in year 2 and at the end of year 3. So these are the challenging situations, patients that have an incomplete response to induction and patients that have the disease come back. But we really tackle these thinking patients can still be cured even in these challenging situations. And obviously, favorable prognostic impact by close monitoring, finding things earlier and then trying to address them early on. I've listed some of the non-myeloablative treatment options. Many of these you've heard about, combination chemotherapy with or without antibody. Several different regimens are extremely effective, even in the setting of prior exposure to some of these drugs. So they list high-dose regimens that we have the published results, as well as low-dose or oral medications. So all non-myeloablative treatment options that exist. Another thing that we instituted back in 2014 is the impact testing. So it stands for Integrated Mutation Profiling of Actionable Cancer Targets, basically looking at the genes and seeing, is there a gene there that a drug can target? So we test every tumor. It is sequenced for 468 gene panel, and we have a specialty team that weekly reviews all the data on all these patients. And it may be that patients can receive additional therapy based on the impact testing, or patients can be tested to see whether there happens to be the rare familial risk. The other genomic platforms that are also in use, and you've heard about these, but they really test similarly, Foundation One, Foundation Act, the MSK Archer panel, and the COG MCI, which you heard about earlier this morning. So innovations in the use of MIBG therapy, very commonly used for neuroblastoma that's refractory or relapsed. We administer it in a regular room. Patients are typically inpatient for 2 to 3 days. Our radiation safety team monitors, and hopefully patients have a great response. Stem cells may be needed, particularly if it's MIBG plus chemotherapy that is used. So my colleague Ellen Basu and Nita Pandit have devised 2 other ways of using systemic radiotherapy that are very much like MIBG. That is targeting the somatostatin receptors, Lutathera. You see on the left a patient that has extensive disease, and then on the right, after 1 injection of the lutetium dotatate, significant resolution of disease. There's also an ongoing trial using the drug copper sartate, which opened in 2020. Now, are there better ways to detect the disease as well as to treat? So MIBG scans, everybody here is familiar with, but we've had the first in human trial of MFBG, and this shows MIBG on the left and an MFBG scan on the right. The advantage to this scan is that no iodine drops are needed since it doesn't go to the thyroid gland. You can get same-day imaging, unlike the typical MIBG scan 24 hours later. It used to be 48 hours later. And there's a higher picture quality. So it may be that a better way of detecting could also play a significant part in the treatment of these patients. So on to CNS disease. The most important thing that I could mention here is that most of you will never have to concern yourself with treatments that are needed. But we still have in our hands, it's approximately 10% of patients will have a relapse in the brain. This tends to occur early. It's not something years later that you have to worry about. It's usually right within 1 year or 1.5 years after the initial diagnosis. And it probably is because the brain, as we know from other pediatric cancers, is a sanctuary site. Cells can hide there, and you wouldn't know they're there until they start to grow. So we routinely screen patients for brain disease, mostly because there is a chance that a tumor in the brain can cause life-threatening issues with pressure or with bleeding. And so catching them early and addressing them earlier can hopefully avoid some of those life-threatening issues. The common symptoms are headaches, nausea or vomiting, sometimes changes in vision, sometimes the right side of the body works better than the left, a focal deficit, and occasionally seizures. In the past, it was very difficult to cure, but I'd like to walk you through some treatment options. So can the CNS sanctuary site be addressed? We do ask our neurosurgeons to resect a tumor if it looks like it can safely be removed, And the advantage of this is it will no longer cause a life-threatening issue with hemorrhage or pressure, but also the mutation status of the tumor may be assessed, and maybe now in 2023 there are some better targeted agents that can be used. We have also used combination chemotherapy. There are several drugs that penetrate into the brain better than others. Radiation therapy to the brain and spinal cord is still extremely helpful, as it is for many children with other kinds of brain tumors. Since 2003, we've been using a form of radioimmune therapy with the antibody that's linked to a radioisotope delivered into the spinal fluid, with the aim there of eradicating micrometastasis. So our target here is something called B7H3, which is on just about every pediatric tumor and most adult carcinomas as well. And this antibody can be labeled with a radioisotope to deliver a focal form of radiation. So the antibody omburtamab was developed in the Chung lab and licensed to Y-mAbs. It targets B7H3, which is overexpressed in neuroblastoma. We know that the tumors uptake the radio-labeled antibody, which could be labeled with 124 for imaging or 131 for therapy. When we give these medications, it is typically into a catheter, into the spinal fluid, but the patients are awake at the bedside and receive a test dosimetry dose, which tells you how much radiation is being delivered, and then a week later, a treatment dose. So we presented these at SIOP last year, 107 patients at MSK treated with the radio-labeled omburtamab, and the survival here, and that is compared to our own internal historical controls that received non-omburtamab related therapy, the 19 patients in the purple. Y-mAbs has also conducted a multi-center trial treating 50 patients with CNS neuroblastoma throughout the United States and Europe. And then at MSK, we've treated 181 patients, including the 107 with CNS neuroblastoma, and then the remaining 72 patients that had B7H3 positive other kinds of brain tumors. In addition, the Pediatric Brain Tumor Consortium, which is 14 centers in the US and Canada, are undergoing a trial using this drug for patients with relapsed medulloblastoma and ependymoma. Now, the decision to approve the drug or not was based on the FDA's review, and they requested what Dr. Brown was referring to earlier, a randomized control trial, which would mean half the patients get the omburtamab and half would get placebo. So the decision to put resources and time into a randomized control trial is really between Y-mAbs and negotiations with the FDA. But it may be that there are better drugs than the I-131 omburtamab, maybe a different isotope, perhaps a different antibody, but that is unclear. Nonetheless, for 2023 right now, we do recommend that the conventional treatments are considered in the event of CNS disease. So that's resection of the disease by our neurosurgeons when possible, the combination chemotherapy that we know crosses the blood-brain barrier, the radiation therapy to the brain and the spinal cord, and then there are several other drugs that also can be effective, oral temozolomide, and for the patients that are ALK positive, lorlatinib, and of course, if we are able to proceed with the intraventricular omburtamab, we would try to incorporate that. Okay, acknowledgements from the many people on my team. Naikang Chung has developed most of the drugs that I've talked to you about today, and my colleague Brian Kushner has published just about all of the references that I've listed, and he's also shared many of his slides with me. Dr. Modak is the service chief, and then the incredible other colleagues, nurse practitioners, our surgeons, neurosurgeons, pathologists, radiologists, radiation safety officers, our research assistants, social work, and survivorship team. If I can just put some faces to the names, this is Dr. Chung and his lab, who are still working on another generation of drugs that will help, and I'm sure Pat can invite him to speak about those in the future. These are my colleagues in nuclear medicine. Dr. Jason Lewis runs the whole program, but the person on his right, Jing, for 20 years has been coming in at 4 a.m. in the morning to start the labeling process so that our young patients who need anesthesia for their scan later can actually get the drug earlier rather than later. So they are all entirely dedicated to making things better for our patients. And of course, some of you may know our nurse practitioners, Ursula and Maria Donzelli, two of my heroes in life. And this is our nuclear medicine team. Nita, who's up on the upper right, starting the MFBG protocol, and certainly involved with the MIBG therapy and copper sartate. And the most important, our inspiration. This is one of the first young little girls that I ever met years ago with neuroblastoma. Her mother is on the right, and like Pat, I don't know how she continues to run with the torch for decades and trying to improve things years after her daughter has passed away. And those are my parents over there who I try to take to every event with me. So they know Katie's family very well also. I've listed so many of the foundations which have supported our work, and the support comes not just through philanthropy, it comes through patient education, awareness, advocacy, and most importantly, emotional support for our team. It helps more than you can ever imagine. And then with permission from the Band of Parents, I am plugging the Band of Parents, an amazing group of people dedicated to bringing better therapies for right now, not 10 years from now. And some of the things I've mentioned have only been given because the Band of Parents develop the resources. So if you are in the New York area, in the Bronx, September 8th, you don't have to even be you don't have to be a golfer. There's plenty of socializing, and it's all with the band's intention of bringing new and better therapies on board. Okay, my favorite quote, I don't know if any of you have seen that movie, Oppenheimer, 3 gripping hours, but there was a nuclear physicist who back during World War II had this line to say, and it's really wonderful, expecting that every child will be cured of neuroblastoma. His quote, "It is difficult to say what is impossible, for the dream of yesterday is the hope of today and the reality of tomorrow." And we really believe that. So thank you for the extreme honor to join you here, Pat and
Thank you for
families.
coming.
Thank you.
Dr. Kramer. Is that Katie Hoke Foundation?
Yes.
Oh, yes, I know them very well, very well. Does anyone have any questions for Dr. Kramer? I do. Okay.
What are, if any, are the preliminary results you're seeing with the MFBG? And if you have a patient who shows maybe lesions on an MFBG but not the MIBG, are you immediately treating them or just rescanning?
Yeah, so fantastic question. It's kind of, in years past, if an MIBG was negative, but you had a strong suspicion that it happened to be the 5 to 10% or so that are not MIBG average, means we would try to do a PET scan. The PET scan is not specific for neuroblastoma. This is specific for neuroblastoma. So Dr. Modak at the last ANR meeting presented the data on the sensitivity with MFBG. I think there were about 30 patients that had both scans. MFBG is definitely more sensitive. You can get the results that day. You don't have to worry about those SSKI drops, which are bitter. Nobody, should have to take anything more, So it probably is going to be, a better modality, which can really help address things earlier and hopefully more successfully. Thanks for the question.
Okay, go ahead.
With that scan, still on the topic, if a kid is MIBG non-avid, would they react to the new scan?
So that's what the trial is designed to assess. It does look like probably yes.
Okay.
Standard of care is to go with a PET scan if you see that the MIBG it happens to be negative.
But have they had children who are non-avid use the new
Yes.
scan? Yes.
Yeah.
Okay.
Yeah.
Okay.
Thank you.
Oh, one more question.
Sure.
For the vaccine,
Yeah.
children that have had the vaccine or started the vaccine, relapsed, and started again, have you seen, I don't know, like results where it's better, worse, or I don't know.
So can they get the vaccine again even if they've
well,
had
yeah,
the vaccine?
I know they can, but
Yeah.
what about the results of it? Is it improved or
Second time exposure. So I'm sure my colleague, Brian Kushner, is probably home writing that up right now if I were to guess. So, but it's a great question.
Okay.
But definitely, offering it as a possibility in the event of a second or subsequent relapse is definitely something that
I was just wondering if it
do.
was better
Yes.
and why, why. I didn't know, because, the antibodies sit there, but if they've had treatment to treat a relapse, like if they've had chemo, would it kill what they've already had before? I don't know. Does that make sense? I don't know
Yeah.
if that question makes sense.
No, it's definitely something to learn
Okay.
more about
Okay.
in that particular setting.
Okay, thank you.
You had a question back there?
Just a quick question, curiosity, and I apologize if I missed this. You talked about the omburtamab
Yeah.
within the setting of patients who had a CNS relapse.
Yes.
And again, I apologize if I've missed this, but has omburtamab ever been looked at for other patients?
Right, so out of the 181 patients at our center that have had the radiolabeled omburtamab into the ventricle, the 107 have had neuroblastoma, and the others are for other B7H3 positive tumors. So those are for babies as young as 6 months, and then for a couple of adult patients in their 70s that had brain melanoma, but the B7H3 was there. So we've tried it, but those numbers for each specific diagnosis are much smaller than the number of patients with neuroblastoma.
Okay, got it. And so you said there were 107 neuroblastoma patients
Yes.
who got omburtamab. And I guess were all 107 of those CNS patients?
Yes, those
They were.
are specifically patients that had documented CNS disease.
Okay.
Yes.
And so just the curiosity then, would we ever look at omburtamab for other patients who are B7H3 positive but maybe don't have something in their cranium?
Yes, and that's part of the PBTC study is
Okay.
to look at it with other diagnoses as
Gotcha.
well.
Thank you.
So, my colleague, Dr. Modak, also has a trial delivering the radiolabeled antibody into the abdomen, into the peritoneum for teenagers that get this rare sarcoma in the abdomen, and then and our neurosurgeon has delivered this radiolabeled drug directly into the brainstem for certain kinds of challenging gliomas. So there may be other indications, but again, moving forward with the antibody will be YMAB's decision. Thank you.
Okay, one more question?
Hi. So a question with vaccine, right? We have, it's maintenance therapy, as like DFMO is a maintenance therapy. Many parents look to it as something to continue to do after standard of care, frontline, relapse, things like that are finished. But with these novel therapies of CAR T, like the gamma, oh my gosh, beta, whatever, coming to the forefront specifically for refractory relapse, kids that are struggling to get back to that NED status kind of thing. And obviously like CAR T is, the hope is, that those CAR T cells are going to keep working, kind of like the vaccine. So is there a place in the line of therapy for vaccine to still be used after something like a CAR T trial, or is the CAR T trial almost like another, maintenance therapy like vaccine would be, or where would how do those correlate with each other, I guess, in using side by side or one or the other type?
Right, so it's a super question. We have never compared, say, the vaccine as consolidation after chemo and antibody versus CAR T cells. But I'm sure there are going to be instances where we feel like everything has to be included, every treatment modality that could possibly address the refractory disease should be included. And if that's CAR T cells, that will be wonderful. So whatever way to get rid of the sanctuary cells or the cells that are refractory to the conventionals, whether it's CAR T cells plus vaccine, I think, we would fully embrace. Thank you.
Okay. Is that it? Thank you, Dr. Kramer. Okay, we'll go ahead and break for lunch now. So at about 1:35, be back here if you can.
approximately 750 children a year are diagnosed under the age of 15.
She told me that Abigail had stage 4. That was the highest stage you can go, and I remember just hanging up the phone and just kind of...
One day there will be cures out there and treatments out there that after children have the response that Drew had, doctors can say to their parents,
office for like an hour, didn't even know what, for the first time in my life, I didn't know what to do. And when I got there, we just started bawling, remember? Yeah.
Just imagine for just
Slowly getting people back in. We're going to go ahead and start. Our next speaker is Dr. Araz Marchalian. She is a pediatric oncologist from Children's Hospital, Los Angeles. She received her undergraduate degree in molecular biology, biochemistry from the University of California, Berkeley, and her medical degree is from the University of California, Irvine. Her residency was done, and her residency and fellowship was also done at CHLA. She focuses her clinical care work and research on neuroblastoma with a focus on translational care in this disease. She also serves as a medical director of the NANT, which is the New Approaches to Neuroblastoma Therapy. She's head of that group, where she oversees the development and conduct of NANT clinical trials. She is the IND sponsor of many investigator-initiated trials and is author of numerous publications. And her talk today is going to be on the trials within the NANT consortium. Dr. Araz Marchalian.
Hi, everyone. I'm going to move this over. Congratulations on making it this far on an afternoon. I am very thankful for the invitation and really enjoyed this meeting. And having all of you here gives me lots of appreciation for all the work you're putting in every day to make this all happen. I am going to talk about NANT today. Of course, I'm presenting on behalf of a big group of people. So I'll try and remember to call out names of people involved in this research. But if I forget anyone, please forgive me. So this is my disclosure. I've done advisory boards, but nothing in my conversation today will affect that. So I'll start with the mission statement, since this is important. And our vision is to cure all children with high-risk neuroblastoma using novel precision therapies. We've been talking a lot about that, developed by expert network of laboratory and clinical investigators. What do I mean by this? First, let's back up for a second. And I was thinking about how to talk about, what is the consortium? Why are we working together, and what are we doing? So I, Googled what a consortium is. Apparently, the strategy story, and there are lots of businesses that define this. And mainly, consortium refers to a group of, could be companies, it could be organizations that come together to achieve a common goal or project. Typically, they have complementary skills and expertise to collaborate and share resources, knowledge, and risks, pursuit of specific objectives. So really, you're thinking 1 + 1 is not 2, but 3, hopefully, or more. So how does this work? We have what's called the Neuroblastoma Program Project Grant, otherwise known as the PPG. So what's a PPG? It supports broadly based, multidisciplinary, often long-term research program. It has specific major objective and a basic theme. It's funded by the National Cancer Institute, and this is a neuroblastoma-focused program project grant. Does it fund everything? No, absolutely not. We wish. But it partially funds some of our work. And within it, the NANT is what we call the translational core, which is taking things from the laboratory to the patients forward. So the goal is to discover and exploit mechanisms of resistance and immune escape. Okay, so established in 2000 as the program project grant. This was started by Bob Seeger. The current PI is John Maris, actually, in Philadelphia. And a group of clinical and lab researchers that designed these novel therapies based on understanding of tumor biology. There have been about 800 kids enrolled on NANT therapeutic trials, their biology trials, and the focus is really relapse refractory neuroblastoma. So how does it really work? So number one, lots of lab work. I'm going to make this just one thing. It's obviously very broad. It takes a long time. But there's a lot of work going on in the laboratory of things that are maybe interesting and maybe not so. But the key here is early collaboration. We're collaborating with the lab investigators as clinical investigators so that we can make sure that the concepts or the lab, even the experiment, makes sense for things that may translate to a clinical trial. Is this logical? Is it not? So in that time, we have some collaborations with industry as well, sometimes families, but really it's in the early phases we're really discussing, is this something that we can bring forward? Is it useful? Is the data good enough that we may want to bring it to a clinical trial? Then comes the fun part where I spend all my time, which is design and execute a study for patients with relapsed refractory neuroblastoma. My partner in crime is Dr. Park, Julie Park, who's now at St. Jude. She's the overall scientific chair. So we get a lot of feedback, try to get funding, try to get the agent. That's harder than you might think, and be able to get the right agent to the right patient, and then work with regulators and just work. But the exciting thing is that eventually, not only do the kids with relapsed refractory neuroblastoma hopefully get the clinical trial, but hopefully, if it's successful, then we can discuss and talk about whether we move it overall to all neuroblastoma patients before they potentially relapse. And that's where COG comes in. So we are working actually quite closely together to try and move this as quickly as possible. How quick that goes, I think somebody asked yesterday, is so variable based on the agent, but there are some times where it all clicks and beautifully, and this is Club America, by the way. This is, but really it's about the teamwork. It's multiple people, just like our Club America friends. So, I'm going to give you, before I get into our trials, I'm going to give you a few examples of you've heard so far, things like, what's an example of how this really worked? For example, the current ANBL 1531 study, which is the phase 3 study that patients are currently enrolled on if they're newly diagnosed today through the Children's Oncology Group. There are two main questions in that study. One is whether MIBG, yes, no, for some patients. And the other question is lorlatinib for the kids who have the ALK mutation. Both of those were a result of the neuroblastoma trials within NANT, and then we worked through them. In fact, at the end of the lorlatinib study was still ongoing when the COG study first opened up. And so that was quite exciting, and how quickly it moved forward. The DFMO study you heard about from Dr. Goldsmith was also based on, chemo, as well as DFMO and the NANT, and then moved over to COG. Things like neuroblastoma response criteria, how to evaluate neuroblastoma, biology bank for relapse disease, et cetera. So these are sort of what I call impact. We'd love to have them very long, and hopefully make a difference in the overall. So these are the sites. We keep expert sites with clinical trial expertise. You can see my little CHLA on the West Coast, which is not raining as of now, and it's cooler. But we're trying to have geographical access for our patients. But we also want to have a good infrastructure for quick translation, so we want our sites to be relatively bigger neuroblastoma sites to be able to have enough patients to make it worthwhile to open all these studies. And I'm going to get to the trials in a minute, but just to give you an idea, we have, from the beginning, had North America sick kids in Toronto part of the new approaches in neuroblastoma therapy. For our lorlatinib trial, we started with the Institute Curie and Royal Marsden in the UK, and we have now an exciting collaboration that's been going on with Princess Maxima, which is slightly different in terms of they're going to be our operations collaboration within Europe to make the translation of our studies easier, because there are some times where it makes more sense to open a study transatlantically so we can accrue faster, get results faster. Of course, not all agents can go across. Some agents can only be in one place versus the other, and so we have to be careful of that. But having the infrastructure so that we can work with the companies who may be providing some of the drugs and making it quick and et cetera. So now that's the structure. Now let's actually talk about the trials. I'm going to focus on just a few sort of big boxes today. One is what's happening with MIBG currently. Two, what's happening with immunotherapy. And then we're going to talk about, how back to the patients, what are we doing, learning from the patients and taking it back. So we'll start with MIBG, and I think you all have been hearing plenty about MIBG, so I don't really need to talk very much, except for, it has been and continues to be an activation agent in neuroblastoma. And our goal here is to really figure out how to improve it, right? We all know, or you may know, patients who have had it. We know their responses, but we would like for MIBG, just like any other agent, to have phenomenal responses. So how do we do that? We need to figure out how to combine it with other agents. So first is figuring out safety and dosing, and improve on the single agent activity. The drugs that you want to combine with MIBG are going to need to be active against neuroblastoma, but they need to sensitize the neuroblastoma to radiation. So you want something that makes radiation work better. You want the normal cells to be protected, and you want to have non-overlapping toxicities, because if you have the same toxicity on top of each other, not very good. So you need to figure out which agents. This is numbers and numbers. They don't really mean anything except for, you can see, I'm going to present a trial that started, or at least conceptually started in 2011 and 2017 and 2021. So it's building on top of each other. So if I can go forward, I have no idea. Okay, here we go. So the reason I'm presenting a study from 2011 is because it's really is the backbone of what has happened in neuroblastoma and in this space. So this was a study, a phase 2 study that took patients and randomized into 3 different arms. One is MIBG alone. We're just going to give them MIBG and see what happens and see what their response is. The other one was with irinotecan and vincristine. The other one was with vorinostat. You have, the patients go through, they get their scans, pre, post, and then you look at who responded best and try and figure out, this is called Pick the Winner study. Very creative, and believe it or not, vorinostat and MIBG was the winner. So there was a significantly improved response rate of that group over the others, which was great and exciting. But of course, we needed to understand why. And we do know vorinostat is a radiation sensitizer. So that mechanism of action made a lot of sense. So at this point, we consider at least that MIBG with vorinostat is our standard. So now we have that, and we need to then figure out how to move it forward. So the next trial was conceptually started in 2017-01. 2011-01 was Dr. Du Bois, who's from DFCI, was the main PI. This study was Dr. Cash, who's from Atlanta, who is the partner of Dr. Goldsmith, who you met this morning. For this trial, what happened was we said, well, MIBG is great. We know there's some activity. Can we combine it with another agent that we know is active in neuroblastoma? And that's dinutuximab. We know dinutuximab has good bone marrow response. We know MIBG has bone marrow. They all have different maybe advantages, and so we wanted to combine them. So we had long track records of agents, and we know what their toxicities are, and if you can time them separately, you can then really harness each agent's activity. So one is you can enhance immune recognition and immune infiltration because you've now given radiation and makes the tumor have an inflammatory response. And then we know that vorinostat actually also upregulates GD2, which means more of this GD2 on top of the neuroblastoma, that more of them come up, and potentially then the dinutuximab could work a little bit better. So this trial is just completed, and the way the trial worked is it's a long list of agents, but it's a little easier than it looks. You start with the MIBG on the first, and then you get out of your radiation isolation. Then you get the next week, you get your dinutuximab. The week after, you get your stem cells back, so you can recover pretty quickly. And then after that, you get dinutuximab again. It's about 3 weeks later. And then at the end, you get your disease evaluation. This was the first regimen. And then we got the results of 1101, which was the study that said MIBG plus vorinostat was a winner. So then we thought, this is great. We've done a lot of this, and we know how to combine this in a safe manner. Then we added vorinostat, if I can. There we go. So with vorinostat, the way we did that is gave it with the MIBG the way it was. That's the only difference, and then we added the rest of it is exactly the same. So giving the vorinostat while you're giving the MIBG, just like 1101, and following it with dinutuximab. All of this was given with GM-CSF, who I know you all love, since it's daily injections. One day we are going to figure out a different version. All right. I don't know why this is getting stuck on me. So we have 3 dose levels on the study, and when we did that, the highest dose level of MIBG was the recommended phase 2 dose because patients did well. There was no real bad toxicity. It was well tolerated, which was exciting because one doesn't know if it's always going to be the same when you're combining agents. The response rate has been encouraging. I want you to all take this with a grain of salt because obviously this is all still ongoing. The preliminary response rate of was 44% for the combination. But when you look at the response rate of arm B, which is with the vorinostat, it was 75%. Again, small numbers, but encouraging data to tell us that maybe this is something we need to look at. And those pretty color pictures, you can tell, is the MIBG score change, and you can see how much better that dose level 4, which is with the one with the vorinostat, was. So this got presented at ANR recently, and we're working on central review to make sure that we can make sure that the data is, the response rate is truly what we need to report out. Now, what's happening after this? Great. Now we have MIBG, we have vorinostat, we have dinutuximab, and we have GM-CSF. So what do we do next? What we need to do is figure out, is actually MIBG with vorinostat, which is our prior winner, is that better or the same than the ones with the dinutuximab? Because we have not compared them. We see some encouraging data, but unless we go back to the randomization question, unless you really randomize and ask the question, there's so much variability, and neuroblastoma is very heterogeneous, that who you get on the study and how things happened, the response rate could be quite different. So you do have to randomize, and so we have a study in the works with the MIBG vorinostat and the 2 arms of 1701. We're excited about the study. However, we're waiting for some drug supply issues right now in order to open the study. So once we get that all resolved, wish us luck, we shall open the study, and we expect this study to open hopefully soon. So how do we then improve immunotherapy is our next step. I don't know why this will not move forward. For immunotherapy, right now, most of the immunotherapy studies that we are doing are NK cells based. That is not to say that we are not looking in the lab or other places with CAR T or other kinds of immune cells, but for today's talk, I'm going to talk about the NK cells because those are the trials that are currently coming up. What are NK cells? They're natural killer cells. I love the name. But they're not the neuroblastoma natural killer cells. They're not the best. They need to learn how to kill better. And so we need to teach them a little bit. So the first thing that we did was 2013-01 study. So in that study, the questions were, can we take NK cells from our kids, take them from the blood, ship them back, grow them, educate them, and bring them back to the patients? Can we do that? And this was done with the blood. And what is the dose of NK cells that we should do this with? And we gave this with dinutuximab. This is pre-dinutuximab immunotherapy. You could see 2013. These studies take a bit of time. And for this study, we show for the first time that we can really do multi-institutional cellular cell therapy. And that it's feasible, because really, in reality, no matter what immunotherapy we're going to do, at some point, we need to figure out how to do this in a multi-institution setting. We cannot just have one drug in one place and nowhere else, and that is not how we want to treat neuroblastoma. And at some point, if it's going to be available to all kids, we need to figure this out. And so we were able to do this. It was a bit of work, but it was great, and we found that the NK cell therapy was safe, but there was no added toxicity. But of course, our NK cells had issues. Our neuroblastoma NK cells were a little wimpy. They did not grow as well as they should. So the yield, the number of cells were not as good as we would have liked. And the timing, so we were getting the blood, shipping them, takes 10 days. These neuroblastoma patients, they don't like to wait around for 10 days while you're just watching and waiting. And so we thought, maybe we should do something. Let's see if we can come up with another way of giving NK cells. So NK cells as an idea are exciting, but maybe we need to figure this out. So the focus has shifted to develop an off-the-shelf product. How nice. Just like we have dinutuximab, maybe we just have the NK cells on the shelf. So we can then give rapid drugs, because it's right there. We can give it more often, because you'll have plenty of them. You can have potential increased efficacy if you can choose the right donor, not our neuroblastoma patient NK cells, which are wimpy, but maybe better ones. And this is actually has some decreased cost, because if you're growing them all at the same time versus individually. This study is going to open in this year. We're very close, and the patients are eligible for any relapse number. I know somebody asked this yesterday. And what it is it's on top of chemoimmunotherapy. So our favorite irinotecan, temodar, dinutuximab that has become quite standard for many of our patients. The patients get that, and then once you're done avoiding the weekend, the next Monday potentially, whenever your timing works, we give the NK cells that are the off-the-shelf NK cells. What are these NK cells? So they're chosen specifically to have more activating KIRs, which are, and there's also something called TGF-beta imprinting. Mainly, these are educated NK cells to be resistant to the immunosuppression that normally neuroblastoma does to make our NK cells wimpy. So mainly, when you're taking the NK cells, you're not only choosing the right donor, whose NK cells are better, just generally, because we all have different kinds of NK cells, and some of us have better ones than others. But then aside from that, you're growing them with TGF-beta, which, so that it can learn to overcome that. We will then see, this is a phase 2 study, so we anticipate to have about 50 patients who will be on the study, and then we will look at the response and try and understand, did we add anything to chemoimmunotherapy as we have. The next study that study is called the STING trial for no good reason, but then all of a sudden we got a honeybee trial. So, and they were named separately and not at the same time, so I don't know what's happening. But you heard about this trial. I think if I can go backward, I will show you. So you heard about this from Sarah Federico yesterday. So we talked about getting more NK cells. The other way to make our NK cells better, instead of giving someone else, is giving something else to make them activated. So in this case, we're giving them IL-15 agonist, which is N803. That's the one she showed with little pictures. It's a subcutaneous injection. And so, of course, preclinically has shown enhanced neuroblastoma cell killing. We know it's tolerable in adults, which is what we always want to know. And there's FDA approval, even better for us. And so we want to give this agent so we can activate our wimpy NK cells. So the honeybee trial this trial is a little bit different in the sense that instead of using dinutuximab, this is a collaboration with St. Jude and their antibody, but otherwise the basis is the same. So we're randomizing this trial because we need to see also this activity of the agent, and since it's not the dinutuximab. Again, this is planned for 2024, in the works, and should be, this is our first study actually with our collaboration with St. Jude. St. Jude is now a new site with Dr. Park moving over there. And so what can I tell you about the rest of it? So, of course, trials are great, and that's what we want to do, but we also want to learn from the trials we've already done in terms of biology. So number one is a little detour to radiology. You heard Dr. Kramer talk about the MFBG study. The MFBG study, Sloan did the initial work. We are now doing the work in a multi-institutional setting for many sites in the country. And the aim is, again, to compare to standard evaluations. The idea is, perhaps it's more sensitive. And if it is more sensitive, we need to understand the prognostic significance. What does it mean if you see another extra spot? Does that matter? Does it not matter? We're not going to be able to answer all of this in this trial, but we are ongoing with recruitment on that study. It's a one-time scan, and we're gathering the data for the FDA so that it could get approval. Because at this point, it has no approval, and therefore, officially, one should not be making decisions on the data because we don't really yet know what it all means. But I do think that it's likely to move forward at some point. It might even move forward towards COG, and us trying to understand slowly how useful is this study, and should we think about any changes in our response criteria. In order to answer some of these questions, we always need to figure out a radiology studies. And so we have been pooling data from multiple studies to try and understand how patients are doing, what are things that are prognostic. So one of the things that we looked at, for example, not very surprising, but a higher Curie score was associated with a worse progression-free survival, meaning, the higher it was, the quicker they sometimes had a progression, and the same thing for overall survival. For example, having measurable tumor and not just bone also had a worse overall survival, and of course vice versa. And we know, and also we've shown, that the refractory patients were actually, going on for much longer and not having relapses as quicker, and they were having longer survivals than our relapse patients. All these things help us in designing the right kinds of studies, because you need to balance the patients in the arms so that it's not biased. So we are doing a current review of our recent studies. This is data from up to 2009. So we are doing this right now, and hopefully in the next year, I'll be able to update you on our new criteria. So we need to understand how to evaluate neuroblastoma. It's all great that neuroblastoma is complicated. I like it, and that's why we're in it, or at least I'm in it. But it is, for most people, there are lots of things to look at. You have a bone marrow, you have the bone, you have the soft tissue. How do they interact with each other? And how do we use our new technologies? How to use MIBG SPECT, for example, that, versus a planar score? How do we interpret low-level bone marrow response? These are all the things that we're working on, and the initial collaboration resulted in the international response criteria revision that are being used in our current studies, including in COG, but I think there's room for improvement. We're working on that actually with our European colleagues as well. So finally, if I don't run out of time, and if I can get this working, a little bit of biology. What do we need to do? We are giving, different agents to our patients, but a reality is that we need to learn when we're successful and when we're not, and why. And sometimes we're able to, and sometimes not, but we do have to have a bank so that we can understand. So we have patients who get bone marrow evaluations. We store a little bit of bone marrow. We get a little bit of DNA, RNA, protein, all the things you heard about today, so that they're all there. We can preserve them and then can have scientific review and decide when these samples should be given, and in little bits, so we can learn something about what's happening with them. So one of the examples, this is a trial that Dr. Ascarzadeh and Dr. Goldsmith, who both spoke today, ran, which was a precision study. We looked at, for example, all the the number of mutations and what percentages, and then try to correlate with immune markers, because that's really important, right? It's not only about the genetics, but it's also the immune milieu of what's happening. And you can see this color coding, I just put that as a pretty picture, just to show there's so much variability. There, certain mutations have more of one immune, I'm going to show it to you, but or different mutations come together while other mutations do not come together. So it's really trying to understand the mechanism there. And last but not least, you've heard a lot about liquid biopsies already, but that has become an area that we've been working quite hard on. Of course, for example, Foundation Medicine or any of the other companies or academic places are able to now do circulating tumor DNA for us. I use it in my clinical practice, which is, and try to understand what's happening. But really, what I do in my practice is one thing, but what we can do as a collective group, understanding all our patients together in their therapies and evaluate them, that's what we really need. And so in this study, there was, clear, these are all patients who were on lorlatinib, one agent, but there was clear, some patients, it would go down and go up, some patients, it would just stay the same, some patients didn't even have detectable DNA. What does all mean? How does that correlate? And these are the kinds of things that we need to do to really, tell our parents, yes, this is what this means. It's going to take us a little bit of time to really understand it, but it is very useful to evaluate what's happening with the tumor and how it's changing as we're treating it. And understanding how it's changing then helps us with another trial design. The same thing happened with our 1101 study, which is the MIBG study that I told you about. And again, in that, we analyzed the circulating DNA. And you can see if a patient's DNA level was really undetectable at day 15, they were going to have a good response. We could already tell, we didn't do it while it was going on, but you could already tell who was going to respond versus not respond to the MIBG. Again, preliminary, but these are the things that we are learning. And then at prior times when I've presented here, we've sometimes talked about messenger RNA, and that's another way to look, not just DNA, but RNA. And we have shown that that's prognostic. The issue with our neuroblastoma patients, they're mostly quite detectable, but for the kids who are undetectable, they do really great. And so how to combine circulating DNA, RNA, and in this space, this is lots of people working on. So what are we doing? How can we work all this out? It's called too much information, and we need to put it together. And so if I could go back, but we have a trial that what we call umbrella protocol that is being developed, where the idea is to prospectively analyze, again, under all these studies that are happening, and also understanding their immune markers. And so sequencing, getting results, liquid biopsy, getting results, but then quantifying things like GD2, immune profiles. But those are not things that you get back results because, again, they're not things that yet what's called CLIA. Some things that are CLIA, then they're the things that are validated that you can get back, and things that aren't CLIA, then they're not useful. We don't know yet. They're useful for us to understand the science, but they're not yet validated to help us making treatment decisions. So last but not least, there's lots of challenges and that you've heard about today, also some successes. I do think that generally our success is going to be combination, multimodal therapy. Learning is definitely bidirectional, right? We're learning from the patients and the laboratory, but it goes both ways, but it requires a lot of infrastructure so that you can go quick and you can translate, you have a nice agent so that we can go forward and get it to our patients. Of course, it's a collaborative effort, and we're really grateful for our parent advisory committee and all our collaborators. And of course, our NANS sites and our staff and our kids. If I can get my cute picture, I did choose a picture of one of our kids or two of our kids. Of course, just like everyone else said, we're not there yet, but we're every day closer than yesterday. With that, I thank all of you and all of our supporters and all our kids and you.
Thank you, Dr. Martelli. Do we have any question?
Yes, thank you for speaking. I was just curious, I had a two-part question. The first part was with the honeybee and the sting trials, how many cycles are given in those trials?
So with the STING trial, we're doing 6 cycles at this time because of the NK cells, and just as preliminary. With the honeybee, it's going to be a little more, and it's probably going to be around 8 to 10 cycles. We're working that out at this point.
And this was more of a theoretical question. With the MFBG, could that ever in the future be converted into a treatment like MIBG?
And I don't, this is more an imaging modality. You'd have to, yeah.
Yeah, I didn't know if they could up the dose.
I would assume that not. I think it would be a very different, because we need different, for example, in the MIBG, it's a long-acting iodine, and so this is really an imaging study.
Okay, that's it. Okay, one more question, and then we have a special surprise.
You mentioned right at the end that you there's a prospective kind of a study or approach looking at the biomarkers of patients that are on the NAN trials. Is there anything in the kind of in the pipes for using a prospective approach to look at liquid biopsies of patients after treatment? Like how they did the Framingham heart study or whatever, to see if there are markers that show up that are early detection of relapse?
Yeah, good question. If you think about that, that really is in the setting of the Children's Oncology Group. And the reason I say that is because this is an upfront setting where we are looking at liquid biopsy in patients who have completed the studies and throughout there. So you will hear, I am sure, there's been some exciting data at Children's Oncology Group about this. But again, the studies have to complete before we truly understand. But yes, in NANT, we are doing that as well. But again, if you think about our relapse refractory population, it's a little more relevant in the upfront setting where you have a lot more patients who have no disease whatsoever. But early detection and understanding that is key for us, in addition to understanding how the tumor is changing while we're treating it.
Thank you.
All right. Thanks, everyone.
Is that it? Thank you. We kind of did this at the last minute here. We're going to have a couple of neuroblastoma survivor stories come up, but we thought about, we had a video that we did years ago, and we would like to play that video for you now and tell me what you think afterwards.
Well, she does have a little bit of fluid in her lungs, and we think that, it's the start of pneumonia, but that's not the issue. He showed us the film. He says this mass here should not be there.
So neuroblastoma is actually one of the most common forms of pediatric cancer. Within North America, approximately 750 children a year are diagnosed under the age of 15.
She told me that Abigail had stage 4. That was the highest stage you can go, and I remember just hanging up the phone and just kind of sitting in my office for like an hour, didn't even know what to do. For the first time in my life, I didn't know what to do. And when I got there, we just started bawling, remember? Yeah.
Just imagine for just a little tiny moment, as little as you can handle, that it's your kid.
And many people haven't heard about neuroblastoma, but in the pediatric world of cancer, neuroblastoma is quite common. It originates in nerve tissue, but it originates outside the brain. So the tumor starts in nerve tissue, either along the spinal cord or there's actually some nerve tissue in the middle of the adrenal gland called the adrenal medulla.
And there was one moment that I knew there was something wrong when she bent over and her stomach was like sticking out, really distended, and we didn't realize that was not milk belly, that was, tumor growing very rapidly.
There's a lot of different ways this tumor will present. So sometimes it just presents as an asymptomatic lump, for instance, in the neck. But much more commonly, patients will present with symptoms related to their metastatic disease. And the tumor metastasizes or spreads to the bone. And one of the most common presentations is patients will present with pain.
So we were in the ER twice with x-rays that showed us that she was full of stool, so we kept moving on that direction until the day that she stood up and fell down because she couldn't stand, her legs were hurting her so badly. Put us to the pediatrician, who put us to the ER, who after several tests found the mass growing in her right adrenal gland, which then after some staging found out was stage 4 neuroblastoma. She had metastasized to her bones and her bone marrow.
And we treat them with very, very intensive therapies. We treat them with very high doses of chemotherapy. They undergo surgery, they undergo radiation, they undergo high-dose therapy and stem cell transplant. And it takes a toll on the family and it takes a toll on the child.
And the thing that really shattered us was when they told us the first round was the easiest. And we looked at that and the state he was in, and we did not think he was ever going to become himself again. So this cancer's taken away our boy already.
Even the children who survive, however, after being treated with this very intensive therapy, they have all sorts of long-term toxicities and they suffer as well.
Me being over 18 is very, very rare. I am at a point where there's not very many options left to me. I have to go around the country looking for different treatments that are available. And I was on this really intense treatment where I had to lay in the bed, and the doctors came in and they injected me with this really intense radiation, and then I had, and everything in the whole room was covered in plastic and paper, and even the remote was in plastic, and then I had lead shields up everywhere in front of me and behind me because I was actually really radioactive. They had injected very strong doses of radiation.
And unfortunately, even with this very intensive therapy and all the toxicities that are associated with this very intensive therapy, the majority of patients are not cured.
We founded CNCF after our son Nicholas was diagnosed with neuroblastoma in 1999. He fought for 4 years and unfortunately lost his battle with the disease. We as a family who had been stricken with it wanted to make a difference and to make sure that everybody in the world knew what neuroblastoma was. It was affecting our children, and we needed to do something to raise money for research, education, and bring about the awareness of the disease.
So CNCF was introduced to us very early on, and she said, let me write down a website. This is the website I want you to go to. She said, you can do all the research you want, but if you want a reputable site that has credible information, and she gave us CNCF website.
So I spent some time on their website and I realized that unlike other cancer organizations, unlike other places we went, this was all about neuroblastoma, and there was information, and there was the information we needed, but there was also hopeful information.
CNCF for us, I think the most important thing I learned or got from them was the handbook that became my little paper or my book that I clung to. It was so much information, and that was a really helpful tool. And then after we were done with treatment, to go to that conference that just is a wealth of information and very beneficial, and one I plan to attend every year.
The conference is a very, very important component of the CNCF, and the doctors have learned from it as well. And then one of the next steps that we have done is provided over $1 million in research funding over the last several years. And it's something that we obviously would like to increase that amount to several $1 million if we can.
There are treatments out there that are potentially sitting on the shelf right now because their money isn't behind them to back them to produce these new drugs. It's critical that organizations such as CNCF raise money, raise awareness, raise funds needed that can save our children.
There's got to be a better way. And the only better way we're going to find is through raising awareness, through raising funds, and through research, providing the funding for the research.
It's important to know that they need your help, they need your support. Hopefully one day there will be cures out there and treatments out there that after children have the response that Drew had, doctors can say to their parents, your child's going to be okay. It's over now, and your child's going to be all right.
Thank you for helping me. Thanks for having me. Thank you, everybody!
That's it. Okay, I'm sure there's some tears here. We did that video 14 years ago, and so to kind of follow up with that whole theme, we have a couple of the little children that were in that video. Oh, stop crying. And I would like to introduce Drew Pershan. He was sitting. And my favorite little girl over here is Paige Sickman. And we're going to have Drew's mom, Kate Pershan. She's going to go ahead and give their little story about what happened from their end to right now. Kate.
Hi, guys. I'm not quite as young, and my skin doesn't look quite as nice as I did on the video. But I'm so happy to be right here talking to you today because I was where you were a few years ago. So here is my little Drew at one of our first conferences. We attended the CNCF conference multiple years. First, during transplant was our first year. We actually left the hospital that day and came here. We live here in the city. And we came to the conference to gather information because he was in the middle of his treatment, and we wanted to make sure we were doing the right thing and doing what all of you are here doing. Several years later, we brought him back and have continued to come sporadically throughout the years. But my son Drew, that you met just a few minutes ago, is now a 15-year plus survivor. He was a stage 4 neuroblastoma and MIC amplified patient at 22 months in November of 2007 when he was diagnosed. So here's Drew today. You saw him, so you know what he looks like now, right? All right. So a little bit about our family. My husband Rob and I we have 2 boys, Drew and his brother Ben. He is a survivor, and I am also a special educator. So I've had 23 years in education, and I'm also an advocate for childhood cancer. My family and I started an organization called the Nick Foundation. You might have seen our logo out by the kids' room. My mom and I started that foundation after Drew was out of treatment to provide some support for families in Northwest Indiana, where we live in 8 counties. So this is our family now. We just headed to, I think that's from Yellowstone. We went to Yellowstone this summer, and it was a lot of fun. It's us. So this next slide is the beginning of our cancer story, because honestly, I was right where you were, and I never thought this would happen to me. I used to tell people that cancer was something that happened to the cute bald kids on TV, right? It was this commercial of something that happened far away in another town, in another life, to someone else. It didn't happen to me. I didn't know people in my community. And so it was extremely scary. I've been hit by the same bus you were all hit with. So just a beginning of our story was the black eye. So on the left is a picture of Drew in September of 2007. And then the picture on the right is Drew in October of 2007. So within a few weeks, he developed a black eye that then turned into a pretty severe, what looked like an injury. He had no other symptoms. He was 22 months old. He was healthy, he was active, he was eating, everything was normal for us except for that eye. And we were very fortunate that his tumor presented somewhere we could see it, because it alerted us that something big was happening. We took him to an optometrist who dilated his eye and said, nothing's wrong with his eye. He's probably just a little boy and getting hurt. And so we kind of did that dance for a few weeks, and then we finally had an ophthalmologist look at it who said, I think I want to do a CT scan and see what's going on. And so again, we really kind of tried to remain casual at the time. We never thought it was cancer. And he went for a CT scan, and he was then diagnosed on November 6, 2007, here's diagnosis weekend when we were at the hospital. So you can see that his eyeball was kind of being pushed out. The tumor there was behind his eye. And they then also found 13 additional tumors peripherally in his arms and legs. He had a 9-centimeter tumor on his adrenal gland, on his left adrenal gland, and the one behind his eye was 2 centimeters, and he was also blood and bone marrow packed at the time. But again, I know that many of you have had the same story where you didn't realize how sick they were because they're small. He had a 9-centimeter tumor in his abdomen, and I was changing his diaper and giving him a bath, and I didn't know any different. So we were, like you said, blindsided, like all of you. I was also 8 months pregnant, so there's a picture, lovely photo of me. But I wanted to illustrate how pregnant I was with our second child. And so going through this was really complex for us. So it was very scary. If you have other children, you know just that their lives are being upended. And truly, honestly, I was scared to be someone else's mom in that moment. I wanted to only be Drew's mom, right? He needed me the most, and how was I going to have a baby and give that baby all the love and attention? He and Daddy shaved their heads in that picture together so that they could look the same when it was time to do that. So there's Drew. He was so thrilled to have a baby brother. Look at him on the left. What is this thing? But truly, I want to say that it was a blessing to have a baby during this. I had a friend from church told me that this baby was going to be a blessing in disguise. And at the time, that was just so overwhelming for me. But I thought, okay. And it was, because I got to also be a normal mom, right? So if you have other children, you know what I'm talking about. You know, you get to go to soccer games, or you get to go home and make dinner, empty the dishwasher. And so for a moment, you get to kind of feel like a regular mom. So Rob and I took turns going back and forth to the hospital and caring for a newborn and caring for Drew with the help of so many, all the grandmas. I can't even imagine how anyone does it without grandmas. So that was our state. That was that part of our journey. Drew did 5 rounds of chemotherapy, and during his chemotherapy, we found CNCF. At the time, this is pre-social media, which sounds like a dream world before we had it, but we found CNCF on the listserv. There was a listserv at the time, and we came to know Pat. And so throughout his journey, we just kind of got to know this community, and it was such a relief to know other people who truly knew this journey we were on and had answers and had information. I was the kind of person who wanted to know everything there was to know about this, and so I needed the information, and I needed this circle. So Drew did, after his chemotherapy, he did have his tumor resected, and we were extremely fortunate that his tumor was dead to the core. So at the time, all the peripheral tumors had dissipated, including the one in his eye, and his tumor was resected dead. And then he went to apheresis, which you can see him there on the right. It took a lot of suckers and a lot of DVDs. You can see our little DVD player and a lot of Matchbox cars to get through apheresis. But we did that, and he harvested for his stem cell transplants here in Chicago at the time. I can't remember the number, ANBL 0621, I think it was, but it was the triple. Do you know which one I'm talking about? He did 3 stem cell transplants here in Chicago. So on the left is one of the, those big complex situations that follows your child around. That was during his transplant there. He has his T-shirt on that says "Got Stem Cells," and we then we welcomed him home. We then went on to do radiation. And then he also did 10 rounds of cisretinoic acid. I think the protocol at the time was 4 or 5. And in LA, they were doing more. And so we chose to try and jump on and see how far we could take it. So we took him through 10 rounds of retin-A. He ended treatment in fall of 2009. And Drew has been event-free and cancer-free since April of 2008. So we're very, very blessed for that. Thank you. So after that, we went back to life, right? Drew was fitted for his hearing aids. He took to those right away. You can see how adorable they were. He went to preschool. He was super happy. He was just the sweetest little thing. We took his Make-A-Wish trip. Of course, we went to Disney. He was 4, right? And we had a great time in Disney. We began advocacy. Here is him with his little brother at Alex's lemonade stand. We did several. We did some events for CNCF. We did some events for Cure Search. We did some for Alex's lemonade stand, and we were just kind of working our way around the circle, right? How do you do that? And during that time, I went back to work. And for those of you who have been through this or been through this multiple times, you know that going back to the world, you're not the same person you were before, and so the world doesn't feel right anymore. So I was very fortunate. I went and had some therapy. I went and saw some counselors, and I got some great advice. She told me that I probably likely had PTSD, and many of you have probably been diagnosed or have suspected. And what I thought was interesting is I said to her, of course, that's for veterans. And she said, you're a veteran and you've been to war. She said, you've seen things that you can't unsee, and you've been places you can't unbe ever again. So you have been to war, and you are a veteran of this. And this is your life moving forward. But she also explained to me, and I don't know if some of you have experienced this, but little things would set me off. I'm a teacher, and my first year back to school, I remember a parent getting upset about a lunch snack. It was a simple situation about a snack got mixed up with another child's snack, and there was a very serious, angry parent about the snack. And I remember before I responded to this email, going next door to my coworker and telling her, how can she be upset about a snack? There's children dying of cancer. And that was really my mind, my eyes were just, I went back. My eyes were just watering, and I was breaking down in my classroom, and she said, Kate, not everything is cancer, right? Not everything is cancer in this, right now, in this moment, right? It's just a snack. It's okay. But to me, I had known what kind of terrible, serious things were going on with children right in this moment. And I thought, how can she care about a snack, right? This is her child. And so I talked to my therapist about that, and she said, cancer is now your 10, right? Imagine all the things that happen to you in your life is on a scale of 1 to 10, right? And 10 is your most intense experiences. So cancer is your 10, but, snack is a 3. Right? It's okay for you to respond to snack at 3 level and respond to cancer at 10 level. And so I thought that was a really powerful piece of advice, that when I try now to respond to things in my life, I try and measure where it is on my scale. It's not my 10. It's not cancer, and I don't have to respond to it that way. When it's cancer, I will respond that way, but when it isn't, I get to tone it down a bit. So that was very helpful. Another thing that we learned, here is Drew with his Eagle project. He just completed, by the way, he's a senior now, and he completed an Eagle project. He built a Gaga ball pit at his elementary school. If you're not familiar with that game, look it up. It's super fun. But another thing that we had to learn through this process was really just to respect each other's path moving forward in and out of the cancer world. So my mom and I talk about this a lot. We still work with families who have a child with cancer, and we know that everyone's journey is very different, and everyone's outcome and everybody's reaction and everybody's involvement is different. So now that I'm no longer a parent of an active child in treatment, I had to find my healthy dose of this world. And you will all discover this as well. When your children are well and treatment has ended, you will discover that for some people, being active in the world means doing this, right? I mean, we're here, what Pat did, and taking this experience and devoting your life. And for some, it may be that you move on and never look back. And you may be somewhere in between, and all of those are okay. All of those decisions are fine. It's how you personally feel you can move forward in this journey. So for me, I found that I had to have a healthy dose somewhere in between, right? I had to find, I can hover a little bit in the cancer world from time to time, and I help run an organization for childhood cancer, and I enjoy my role in that. But I also know where my limit is, and I call that my healthy dose, right? You have to know what your dose is and what your healthy dose is. My husband and I had to learn that our doses were different too. He wanted to move on, and I see some folks nodding their heads. He wanted to move on, but we have very different roles. We're both still advocates, and we're both still very much, we love telling Drew's story. But how we do that, we had to respect each other's differences and how we move forward. So where is Drew now? He's right here. He still has a yearly visit at the hospital. We're here at Lurie Hospital in Chicago. And he has a team of doctors that he sees. He does suffer from some long-term side effects. He has some hearing loss and wears hearing aids. He does see a cardiologist, is under some cardio restrictions just for heart safety. We did work with some growth hormones and an endocrine specialist as well for some of those things. And then just other, small issues over the years that we've dealt with. But we always say, I don't care if he's purple because he's here. And so we knew early on whatever issues we had to deal with moving forward meant we had moved forward. So that was okay with us. All right, so Drew I know this is the part I loved hearing the most, was that Drew does so many amazingly normal things. He's an athlete, he's a scholar, he plays baseball and volleyball. He is an amazing friend, he's a scout, as you saw. He's incredibly bright. We travel, we do all the things that our family dreamed of doing years ago when we were in your seat. And you will do those things too, and you will be here on this podium, you will. And I truly believe that. So, some lessons I've learned. I've gone over my time, and I'll try and be fast. I'm sorry, because we have an amazing guest after me. That there are so many good people in the world. You know these things. You're learning this through your journey. As I said before, seek help. Find help from family and friends, but also from therapists and counselors. Find this tribe right here. You found it, and you're already there. Other folks who truly say, I know what you've been through, and not when you say my child has cancer and someone says, I know how you feel because my grandma had cancer. I feel folks are laughing because you've all heard this from someone, and I just see, right? My mom is like pretending to punch someone right now. Because my grandma did have cancer, and it was very difficult for our family, but it was not a person that I birthed and would literally let a train run me over for. So it's not the same. It's not the same. I had to find my tribe. I've also learned that not everything is a 10. I explained that one to you already. And that you need to know your dose. And it's okay to have a dose that is 0, right? When you move on from this, it's okay to move on. And to respect each other's dose, like I said. My husband and I had to learn to coexist in that space. And then things that I've learned about parenting a survivor, which I'm very excited to share with you because you will all be parenting a survivor someday, and this will apply to you. Try not to overreact to every time they say they have a headache. It's hard. Kiki's shaking her head. It's very hard. And pick your battles, right? Just like any other kid. Learn to advocate for them, just like you have been doing, but also teach them to advocate for themselves. Drew has always been part of his medical conversations from the time he was very small. However, it was appropriate to involve him in those conversations, we did. And we still do. Now he is 17, and so the decision goes to him first, and us second. We ask him his opinion first, and he drives that bus. And also let them choose their own dose. Drew's involvement in this world is very different than mine. He is proud to be an advocate for childhood cancer, but in his own way. And that's okay, and I respect that. And then again, involving them in their decisions as they grow. He's learned that he has to have a lot of medical information at his fingertips. He needs to know those things about himself. And so we have a lot of frequent conversations about that. But I'm excited. He's 17. He's getting ready to start his senior year in high school and go off into the world. And this is what I always dreamed that we would have. And I wanted to just thank all of you for being here. Whether your child is here on this earth or in the next life, I want you to know that there is hope for kids with neuroblastoma. And I'm so happy to be part of this success story to share with you today. So thank you to all of the children and their families and everyone who's made this event a success, and keep fighting.
Okay, thank you. Oh, sorry. Thank you. We have another speaker. Again, you may recognize. You probably won't recognize. A young lady that we met and filmed 14 years ago in that video. And to see her, when do we see? First time this week, right? To see her for the first time after 14 years was just truly an amazing gift. And so we wanted her to speak at the conference. So here's our lovely lady, Paige Sickman.
Okay, so I'm going to try to do this without crying because it's been pretty emotional. Okay. So hello, everyone. My name is Paige Zickman, and I wanted to first thank Miss Pat for inviting me to speak at this conference. I feel very blessed and honored to stand up here today and share my survivor story as I approach my 16-year remission anniversary. So my story, I was first diagnosed in March of 2007 when I was 17 months old. I was experiencing symptoms of reoccurring high fevers and severe abdominal swelling, which was later confirmed by doctors as stage 3 intermediate risk neuroblastoma. My parents were always told by doctors that my cancer was by the book. I just had one tumor wrapped around my aorta, and all I needed to receive was the standard protocol of 4 rounds of chemo and a tumor removal surgery. Although before I was able to start chemo, I had a complication during my tumor biopsy. The tumor and my pancreas were in close contact with each other, which led to my pancreas being cut. I was then hospitalized for 2 months where I received inpatient chemo, physical and occupational therapy, and only received food through my central line. As my mom explained it to me, pizza in a bag. I was later released in May where I completed my last round of chemo and had a successful tumor resection surgery. In that following August, I had no evidence of disease. My time at Comer Children's Hospital and the amazing medical professionals that worked with my family has made a lasting impact on the way I live today. Although I was so young and I don't remember my life during treatment, having cancer has still affected my life tremendously. Oh my gosh, this mic. Physically, I'm a normal 17-year-old girl, and I don't face any side effects as a result of my treatment, but I do continue being seen yearly at the Comer Children's Hospital Survivor Center for follow-up on any late-term chemotherapy or surgery complications. However, cancer did leave me with a 6-inch scar across my abdomen, as you might have seen in the picture earlier, as well as several smaller scars across my torso. I can stand here today and talk about these scars, as I have grown to learn how meaningful they are to me, but it wasn't always that easy. Growing up as a teenage girl with a body that didn't meet societal standards was extremely difficult for me. I found it hard to accept the scars and learn to love them when they came from a part of my life I don't remember living. I'm grateful to have the support system of family that I do because they played a huge part in reminding me the importance of the scars I once considered a burden. In fact, in my household, we don't even call them scars anymore. Instead, we say they're kicked cancer's you-know-what marks. My scars represent more than just my past, but the strong person I am today and the future I continue to work towards every day. I would like to share with you what life looks like for me now, as I am living proof there is life after cancer. I'm entering my senior year at Carl Sandburg High School in Orland Park, and I am getting ready to apply to colleges in the fall. I am in all honors and AP classes, involved in over 10 clubs, and was inducted into the National Honor Society last year. I love spending time with my family and friends, and just like a normal teenager, I absolutely love to sleep. Having had several blood transfusions myself, I advocate for the importance of blood donation through my school, as well as myself donating every 8 weeks. I am currently in contact with Vitalant Blood Drive Company to organize my own blood donation within my community. I have also donated my hair to make wigs for cancer patients 3 times. I have accumulated over 300 service hours, more than half completed at Northwestern Hospital. Having cancer has allowed me to see the inside of the medical field, and from the time I could talk, I have always expressed my dream of becoming a doctor. I still stand by that dream today with a plan to major in biology on a pre-medical school track and eventually become a pediatric oncologist. The thought of being able to give back to kids and families that are going through what I went through and supporting them the way I was supported truly excites me, and I couldn't imagine going into a different profession. My passion for the medical field has driven me to get involved in as many activities as I could throughout high school. I am vice president of medical club at my school, where I run the competitive division team called HOSA. HOSA is an international student organization that promotes career opportunities in the healthcare industry. HOSA has over 3,000 different topics you can choose to learn about, ranging from dental science to medical terminology to physical therapy and so much more. The specific field I competed in was CPR first aid. I was given one of 19 scenarios to memorize, where I had to perform CPR in front of a panel of judges on any given age dummy, or provide first aid to a conscious person that could have had broken bones, severe burn, or was choking. I placed 3rd in the state and got a bid to HOSA Internationals, which was the summer competition hosted in Dallas. And at Internationals, I was able to talk with several medical professionals, listen to intriguing keynote speakers, and further my passion for the medical field, as well as meet students from all over the world, such as South Korea and Norway. I am also a committee chair for an organization called Relay for Life at my school. Relay for Life is a movement dedicated to helping communities attack cancer, and in my district, it is one of the most important events of the year. Our goal is to honor those impacted by cancer, increase awareness, and raise money for the American Cancer Society. This past year, our school raised more than $20,000. I'm so glad to be standing here today at the same conference my family and I attended so many years ago. The CNCF conference brought incredible support to my parents during treatment, and to come here again with an entirely new perspective on life is truly rewarding. To any doctors in this room, I thank you for the extraordinary work you continuously put in every day. I aspire to be one of you someday. To the fighters currently in treatment, there's always hope beyond what you see. It's possible not just to survive, but to thrive and to live a healthy, amazing life again. You can and will be on the stage one day. To the families, my parents were in your shoes once. The warriors are not just the patients receiving treatment. To be making countless decisions in moments of chaos and continuously advocating for your child requires an incredible amount of strength, and I just want you all to know you are truly inspiring. I encourage you to lean on each other, your faith, and never lose hope. To my fellow survivors, it's an honor to be amongst you. I absolutely love meeting each one of you. We are a powerful community. It is important we stay connected with each other. On behalf of my family, my mom here today, we wish you all health, strength, and healing always. Thank you.
Okay. All right, I'll finish up here. All right, we're going to take a little break. I can't imagine the inspiration that Drew and Paige and then the other survivors that are actually out eating tons and tons of steak. Right now, they went to iFly in Rosemont, so they're skydiving. So they're having a great time, and they're all eating steak now. Yes, I'm very happy for them. And they've all bonded together now. For them, you don't see, how many times do you ever see a neuroblastoma survivor and you actually look at one, right in your face? It just doesn't happen that often. So we appreciate the opportunity for you to come and inspire all of us, the moms and dads here and the doctors here. So thank you very much for your talks, and for Kate too, from a mom's perspective. We're going to go ahead and take a break. We do, if you're still going to be here and you're not traveling or anything, we do have one more speaker that we're going to be doing by Zoom. It's Dr. Patrick Reynolds from Texas Tech University in Lubbock, Texas. He's going to be doing a talk on the biomarkers of neuroblastoma. So if you can hang around, I didn't know if anybody has to leave, but we're going to try to get him at about 3:30, so you got time to kind of mill around and do things. So hopefully be back here at around 3:30. Thank you. If anybody hasn't gone into the break room to get cookies, please go in there and get rid of them, eat them, take them with you. There's plates and plates and plates of cookies, so please go take them.
Hello?
Them and me both. Yes. And he became a Hulk, didn't he? I'm Really? It did? Tortured her. I feel like, okay, well now they don't do it anymore. Okay, however many we have left, we have another speaker, our last speaker of the day of the entire conference. Our next speaker is Dr. Patrick Reynolds. He's from Texas Tech University in Lubbock, Texas. Dr. Reynolds is a member of our medical advisory board, and he's a true inspiration to so many people, you know, with the amount of research that he has done on neuroblastoma and what he's done for all of our children. So he has a talk today on the biomarkers, newly found or hopefully newly found biomarkers for neuroblastoma. So Dr. Patrick Reynolds.
Thanks, Pat. Can you guys hear me okay? I'm not getting any response. I just want to make sure the audio is working before I start.
Can you hear us, Pat?
I can hear you. Can you hear me?
Yeah, we can hear you.
Okay, great. That's all I needed. Now we can get started. Thank you very much for the invitation, Pat. I'm sorry I couldn't be there with you. Have a planned quite a time ago, all four of my grandchildren and their parents joining me, and so they were here this weekend and not possible for me to travel. Let me get the screen sharing going here. All right, and we'll get this up. And I believe you should be able to see the slides okay. Let me know if you can't.
Yeah, they're there.
Just the main ones. Okay, great. What I want to talk about today is some emerging biomarkers for neuroblastoma that I think will impact the way we think about how we give certain therapies. And this is early data. We presented it, there's two different abstracts that I'm showing you that we presented at ANR here today. These have not been published in a peer-reviewed journal yet, so there's still some work to do on it. And of course, there's confirmatory studies to do with these data. But I thought at this point it was, and so did my colleagues in the neuroblastoma